So let us begin, guys. Today we will be doing some very important topics which you should take full benefit of. Okay, let's start because we are left with still some amount, and hopefully we will finish everything today and tomorrow, whatever is left. So today we are going to do trauma. Very important. You will get 3-4 questions in trauma. Whichever exam you give, 3 to 4 questions you will get directly. They should be in your pocket. ओके एकदम आपकी जेब में होने चाहिए क्वेश्चंस एंड ब्रेस्ट एंडोक्राइन थायराइड you will get 1 or 2 questions each from them, but they overlap many other subjects, so it can be breast surgery, it can be pathology, anatomy, physiology, सब मिला के, right? So let us try to get full advantage today of what is left. So today you will do trauma, breast, endocrine. If something gets left from thyroid वगैरह, we will do it tomorrow with urology. Tomorrow we have urology, बोन्स प्लास्टिक सर्जरी, दैट इज व्हाट इज लेफ्ट. तो उसमें जो भी आज बच गया थोड़ा कॉम्पेंसेट कर लेंगे, ठीक है? होपफुली टुमारो तक वी विल फिनिश एवरीथिंग. इफ एनी स्मॉल टॉपिक्स गेट लेफ्ट, यू कैन लेट मी नो, वी कैन डिस्कस देम इन द एग्जामिनेशन एंड डिस्कशन वाली क्लास. उसमें छोटे मोटे कोई टॉपिक जो रह गए तभी कर सकते हैं, विच डोंट नीड टू बी डन सेपरेटली. ठीक है? सो लेट अस बिगिन and let us start with the first thing. So we are starting with trauma. Trauma, you need to know general trauma, head and neck trauma, chest trauma, abdomen and pelvis trauma. These 4 things you need to know in trauma. Okay. So अतुल कुमार को भी सेम कसरे बाड़ा अभ्यास कर व्यवस्थित वाच व्यवस्थित ऐक. Okay. So no more needless discussion, only academic. Only academic. Don't say when will you give break. Break will be given at 6:30, dinner break at 8:15, and end of the story. Okay, 2 breaks you will get. If you are tired in between, you are free to take a break for yourself, and whatever you miss you can watch later or forget about it. आपके ऊपर है. बाकियों को पढ़ने दो, जो पढ़ने आए हैं उनको पढ़ने दो. So let's start with trauma. Very interesting, very nice. Every surgeon should know, every doctor should know about trauma, and this will help you a long way, not just for entrances. Entrance में तो आएगी इससे सवाल, but और सब जगह पे भी it will help you. So make full use of this. So whenever there is patient who comes with trauma, trauma can be road traffic accident or trauma in the house. Your wife beat you up or your girlfriend beat you up, more applicable to you. Server फोड़ दिया. How should the management be done? What should you do first? What should you look after? What can kill the patient? All this is given or defined by what are called as ATLS guidelines. Okay, so there is a committee which is called ATLS. ATLS stands for Advanced Trauma Life Support. Like how you have advanced cardiac life support, same way you have advanced trauma life support. Okay, this is a committee which makes guidelines, like how you have Indian committees, same way. Same way, ATLS, it's an American committee. They give you trauma guidelines. So what do they tell you is any patient who comes with trauma, the first thing you should do, the first step, is what is called as primary survey. Okay, primary नाम से समझ गया. Primary means what you do first. Survey means look, देखना, survey करना, जांच पड़ताल करना. That is called as primary survey. What do I do, or what is the purpose of primary survey? It is to identify what will kill him immediately. So to identify life-threatening injuries means whatever can kill him immediately, they have to be identified, and if possible, they have to be treated. So you have to identify immediate life-threatening injuries. And what you are supposed to do at the end of primary survey, patient should become stable. So you have to stabilize. आई बात समझ में? So primary survey में हम जो भी चीज करेंगे, keep this in the back of your mind that the effort is to stabilize. Stabilize means if person comes with trauma, he has lost lot of blood, his pulse may be very high, his blood pressure may be very low. So this has to be brought to nearly normal. His breathing should be brought to nearly normal. Oxygen should become normal, near normal. That is the aim of primary survey. So what is done in primary survey? Anybody knows? क्या करते हैं हम primary survey में? पढ़ा होगा शायद. Maybe. ABC. Okay, so what you do in primary survey, correctly said, is given by the dictum A, B, C, D, E, F. Okay, different books will give you thoda alag, but in principle it is A, B, C, D, E, F. This is what you have to follow. It's a, that is, they are mnemonic. Mnemonic is MNE mnemonic, or not PNU. Mnemonic nahi hai, MNE hota hai. Anyways, so you start with A. This is the first thing you are going to do. A means what? You have to check his airway. But not just airway, you also have to check his cervical spine. Okay, you have to check two things. It is airway and cervical spine stabilization. So you are going to do these two things, airway and cervical spine stabilization. Now, what do you check in airway? Airway means nose, oral cavity, larynx, trachea. That is airway. You are looking for, is the airway blocked? So you want to know, is there airway obstruction? Because if the airway is blocked for whatever reason, he will choke to death. वो फौरन मर जाएगा within a few seconds or minutes. एयरवे ब्लॉक हो गई तो ट्रॉमा में हो सकती है एयरवे ब्लॉक. तो पता कैसे चलेगा एयरवे इज ऑब्स्ट्रक्टेड? The first thing you are going to do to check for airway obstruction is you ask him to speak a sentence. Okay, he has to speak one full sentence. Don't ask him how are you and he says fine. वो नहीं चलेगा. You ask him to speak a sentence. So at least 3-4 words he should be able to speak. If he is able to speak a sentence comfortably, that means airway is patent. Airway is not blocked. Very good. So if he is unable to speak, like you try to ask him, what is your name? And he says, my name is Siddharth. Oh, my name is ऐसे अटक अटक के. So if he's not able to say, my name is Siddharth Chaudhary, you will say airway is obstructed. So if he is unable to speak, or he has stridor. You know what is stridor? That sound that comes, when your airway is blocked. That sound, that is stridor. If there is stridor, obviously airway is blocked. Goes without saying. Or if Siddharth is unconscious. Agar aap unconscious ho, obviously you won't be able to speak. And if you are unconscious, it is assumed that your airway is blocked. It is assumed that your airway is blocked. Something has to be done. Now, before I do anything to unblock the airway, the next step is going to be cervical spine stabilization. So I hope, Siddharth, this will answer your question. The next step is going to be cervical spine stabilization. And how do I stabilize it? I will stabilize it ideally by applying what is called a hard cervical collar. Now I will ask Siddharth, why do I need to do this cervical stabilization? ठीक है ना, ट्रॉमा है, ये गर्दन से क्या संबंध है? Why should I put a hard cervical collar? जरूरत क्या है? Is it necessary? And this will also answer his query that should I do airway or should I do cervical spine stabilization? To make breathing easy, no, it will not make breathing easy. It will not protect C-spine. The thing is, when I have polytrauma, I am not sure does he have a neck injury. Okay, I am not sure yet. I will have to do X-ray. I will have to do examination of his neck. I will have to do X-ray. So some tests have to be done if I am suspecting cervical spine injury, which I can't do immediately. फौरन तो नहीं कर सकता. But I also want to protect his airway because airway obstruction can kill him. So what I have to do is, before I do anything for his airway, like intubation, अभी intubation में मुझे ऐसे करना पड़ता है. I cannot intubate him just like that. Neck has to be extended. Or if I want to check his oral cavity. So basically, before I do any airway maneuver, I have to protect his neck. It's a preventive measure. I don't know it's injured or not. Preventive, I am checking. So when I apply the collar, neck will not move. It will be protected. Later on, I can see is there any injury or not. आई बात समझ में? So before any airway maneuver, you will immobilize the cervical spine and then you will try to relieve the obstruction. So this relief of obstruction, if it is obstructed, is going to be done after cervical spine stabilization. So whatever I do, airway, breathing वगैरह वगैरह, cervical spine fix करके करूँ ताकि वो हिल नहीं जाए और इंजरी अगर हो तो वो बढ़ नहीं जाए. It should not get worse. So I apply the collar. Yes, even breathing करने के लिए भी आपको कुछ ना कुछ करना पड़ेगा. So before you move to breathing, you will do cervical immobilization. Before you move to anything, patient का कुछ भी maneuver करने के पहले neck has to be fixed. Unless you are sure that neck is not injured. If you are sure, you don't have to apply. Like if person comes with an abdominal stab and nothing else is injured, तो collar लगाने की जरूरत नहीं. But yeah, in principle or MCQ, this has to be done first. So first check airway, immobilize cervical spine, then relieve airway obstruction in this order. Okay, this is the fundamental that you need to understand. So confusion नहीं होनी चाहिए. Airway first, C spine first. Okay. Now, how do I relieve airway obstruction? Depends on the reason. What do I do first? I will try to open his mouth. Airway obstruct क्यों होगी? Maybe he got an injury in the mouth. There is some bleeding. Tongue got cut, and there is a blood clot in the neck. One of the reasons. So what I do is I open his mouth and remove any obvious obstruction, like a blood clot or broken teeth or बाहर से कुछ अंदर चला गया. Remove anything obvious. If that is not the reason, let's say there is nothing inside it. Let's say he's unconscious. Then what will I do next? I will do what is called as chin lift, jaw thrust. But this obviously is going to be temporary. Chin lift, jaw thrust. तो ऐसे कर दो. उससे थोड़ी एयरवे खुल जाती है पूरी टाइम, पर पूरा टाइम तो ऐसे रख नहीं सकते. Eventually, if his airway remains blocked, I need to do something more certain, something that will supply oxygen to his lungs completely. ये सब तो temporary है. Open mouth, chin lift. There are other things also you can do. Like you can put what is called as oropharyngeal airway. आपने शायद anesthesia में पढ़ा होगा. Oropharyngeal airway डाल सकते हैं. All this is temporary. थोड़े टाइम के लिए काम करेगा. Giddels airway, absolutely right. It's called Giddels airway. All this is temporary. Finally, you need something more definitive. So you need something more secure or definitive. And obviously, the best airway, most secure and definitive, is going to be endotracheal intubation. Nothing better than that. Once you've done endotracheal intubation, airway part is managed. Now you are sorted. Now airway will be unobstructed. Endotracheal intubation is the be all end all. पर कभी कभी क्या होता है ना, endotracheal intubation, sometimes it's not possible because there is some problem in the oral cavity. Maybe mouth is not opening. Maybe there is a oromaxillofacial injury. ये सब जबड़ा उसका fractured है, खुल ही नहीं रहा है. If there is a oromaxillofacial injury or he has laryngeal edema, so trauma has injured his larynx, you're not able to put the endotracheal tube. He is choking, his airway is obstructed. In this case, what you are going to do is called as front of neck access. Front of neck access. Front of neck access is FONA. How do you front of neck means यहाँ से आपको कुछ डालना पड़ेगा. क्या डाल सकते हो? दो choices है. If you want to do something immediately and temporarily, something which is immediate but it is also temporary, it's not secure, you will do what is called as cricothyrotomy. Okay, you will do what is called as cricothyrotomy. Needle के साथ कर सकते हैं. You put a मोटा सा needle here in the cricothyroid membrane and attach oxygen to it, and oxygen will go through that. So you put a needle here in the neck directly into the cricothyroid membrane and give oxygen through that. The problem is this can be used only for 15 to 30 minutes. It's a very temporary airway. Eventually, what you will have to do is something more definitive or secure. That you know better than me. That is going to be tracheostomy. जहां कुछ काम नहीं आया वहां tracheostomy कर सकते हो. it is the last resort where nothing will work, you can do tracheostomy. So basically, if you are not able to intubate for some reason, like there is a fracture in the oral cavity, mouth is not opening, or larynx is swollen, laryngeal edema, tube is not going, you don't have the expertise. In that case, you can either do a front of neck access, needle cricothyrotomy, or you can do tracheostomy. Okay, cricothyrotomy easy but temporary. Why not direct tracheostomy? Because it's not possible for everybody to do tracheostomy. Tracheostomy is like a surgery. अगर आप emergency में कर सकते हो तो ठीक है, but everybody is not able to do it. So what they do needle cricothyrotomy. You buy yourself some time and then arrange for someone to come and do the tracheostomy. Tracheostomy के instruments चाहिए, anesthesia चाहिए. So if possible, you do it in a controlled environment. हाँ, अगर cricothyrotomy से भी काम नहीं हुआ, tracheostomy कर सकते. Because tracheostomy is definite. Okay, it is definite. So if they ask you best step, tracheostomy. Yeah. Because it's very small, it's just a needle and oxygen will go in, but carbon dioxide will not come out. So person will have CO2 narcosis. Carbon dioxide will start building up. So he will get CO2 narcosis. Okay, which is why I cannot do it for a long time. छोटी सी needle होती है, उसमें oxygen डाल सकते हो, बाहर कैसे आएगा कुछ? So the carbon dioxide will keep building up inside the body. After this is done, your airway obstruction should be resolved. Then you move to the second part. That is going to be breathing. Now, breathing means you are going to do a very brief, very quick breathing checkup or respiratory checkup. So you do a quick respiratory system examination. तो उसमें आप क्या करते हो? You just do auscultation, percussion, little palpation, inspection. All this you will do on the lungs, basically on the chest wall, to see is there any evidence of tension pneumothorax, or is there any evidence of cardiac tamponade? All these diseases we will discuss in detail later. I'm just giving you an example. So these kind of things you will try to establish in the breathing examination. If they are there, they have to be treated ASAP. The third thing you are going to do is going to be circulation. Circulation में क्या करेंगे? What do you do in circulation? That scene from South movie. Very good. So what you are going to do, very good, is going to be you check his vitals. Vitals means pulse, blood pressure, JVP. Already you may have done oxygen, pulse oximeter. You may have already done it. So you do check these things. See, is the pulse very high? Is the BP very low? See, is the person unstable? यहाँ पे पता लग जाएगा. And if he looks to be unstable, the first thing you are going to do is you will take 2 large IV lines. Because he must have bled a lot, that's why his pulse has become high. Volume kam ho gaya, blood volume. So you take 2 large IV lines. At least 18 gauge. At least 18 gauge is the green one. Ideally, you should take 16 gauge. But 16 gauge, many times it is not possible. 16 gauge is the gray one. So you take 2 IV lines if possible. And from the IV line, you are going to give IV fluid bolus. How much bolus? 1 liter of warm crystalloids. Warm means it should not be fridge se nikala hua. It should be at least little closer to body temperature. 1 liter of warm crystalloids. Crystalloid means normal saline or ringer lactate. ऐसा कुछ दोगे. You will give crystalloids. Okay. So you give IV fluid bolus. What will happen when you will give IV fluid bolus? Most probably, so some blood volume gets restored. So most probably pulse will come towards normal. Blood pressure will increase a little bit. He will start becoming stable most probably. At the same time, there is one medicine you can give, which is called as tranexamic acid. This also helps in stopping the bleeding. You may have studied in OBGYN. Abnormal uterine bleeding वगैरह में देते हैं PPH में. You can give tranexamic acid 1 gram bolus, ideally within 3 hours. Okay, ideally it should be given within the first 3 hours of trauma. So you start with these things. Yeah, so this becomes your airway, breathing, circulation. One question before I move on to disability. Do I have to always do airway, breathing, circulation? Or can I first do breathing? Can I first do circulation? Can I change the order, or it's a compulsory order? ये order follow करना जरूरी है क्या? If yes, why? If no, why not? Yes, no. Okay. So please understand, you have to follow this order compulsorily, irrespectively. It's because this order has been made for a reason. It's because airway obstruction kills you the fastest. It takes the least time to death. That's why you have to treat airway obstruction first. Breathing problems will kill you second fastest. Circulatory problems, third fastest, and so on and so forth. So your order has to be A, B, C, D, and not C, A, B. In some other places, like in cardiac life support, you will do C, A, B, but that's in cardiac arrest patients, not in trauma patients. Okay, that's in cardiac arrest. So this A, B, C, D has been made not because it sounds easy. ऐसा नहीं है. It's because airway will kill first, breathing will kill second, circulation will kill third, disability will kill fourth, like that. So the order has to be this. This becomes your airway, breathing, circulation. Then you move to next, that is going to be disability. Disability simply means that you are going to do a quick neurological examination, very quickly, very briefly. If this is deranged, you will think maybe there is some problem in the brain. You do a quick neurological examination in which you check only two things. The first thing is called as GCS. GCS or Glasgow Coma Scale, जिस पे question आते हैं. So you check the Glasgow Coma Scale. And the second thing that you are going to check are his pupils. Are they dilating? Means are they reacting to light? So when I throw light in the eyes, will the pupil constrict or will it remain dilated? So I check the reaction to light. Okay, so far so good. So this is the disability assessment. Now, in this GCS, there are many questions that can be asked. So you should know a little detail about what is GCS, how it is calculated, what are the components. So first and foremost, why do I check GCS? Don't include it unless they specify. Okay, don't include it unless specified. Why do I check GCS? What does it tell me? Intracranial injury, patient response, below 8 intubate, severity, reaction of person. Reaction to ऐसे भी कर देगा यार. Okay, so GCS has many uses. The first use is it will tell me, is there head injury? That is number one. So it will help me in understanding, is there a head injury? But more than that, it will tell me the severity. Severity means, is the head injury mild? Is it moderate? Is it severe? And the third thing, even more important, is it will give me prognosis. Prognosis means, is the person getting better? Is he getting worse? For example, he's come now with trauma and his GCS, for example, right now, let's say it is 10/50. For example, and let's say I check it again after 1 hour, and after 1 hour, it has become 9/50. I check again after 1 hour, it has become 8/15. What does this tell me? What does this tell me? Yeah, very good. So it is telling me this GCS is deteriorating, which means the problem in the brain is getting worse and I should do something. Okay, it tells me that he is deteriorating and I should do something. On the other hand, it can be the other way also. Like when he came, it was 10. Then after 1 hour, it became 12. After 2 hours, it became 15 by 15. So it tells me he is improving neurologically. So I get an idea of prognosis. I can keep checking up. It can be done again and again. The score that I get in GCS, the maximum, I will tell you how it is calculated, is going to be 15 by 15. What is the least score, lowest score? What is the least score that you get in GCS? Can I get 0? So theoretically, it is 3 by 15. Theoretically. But this will only happen if all components can be tested. अगर सब कुछ टेस्ट होगा तो ही, if all components are testable. So इसलिए practically we assume 3 by 15, say 15 by 15 is the range. In mild head injury, the GCS should be 14 or 15 by 15. In moderate head injury, it should be between 9 to 13. In severe head injury, it should be less than or equal to 8. So depending on a GCS, I can tell mild, moderate. Okay, so that's why they say if GCS is below 8, you should intubate because his airway will get obstructed. वो एक saying है, GCS below 8, intubate. Right? So 0 नहीं होता, theoretically तो नहीं होता. Yeah. So this is what tells me the different levels and values of GCS and its uses. Now you need to know how to calculate it. कि इतना हम क्यों इतनी रामायण डिस्कस कर रहे हैं, इसको हिसाब तो बताओ कि ये 14 by 15, 9 by 15 आया कैसे. So anybody knows how to check GCS? What are the components? Dead नहीं होता. GCS will not tell you patient is alive or dead. Okay, let's not do that. So you check 3 things. You check the eye opening, but the best eye opening. You check the verbal response, best verbal. And you check the motor response, but again, best motor. And each of these is given points. So eye opening goes from 4, 3, 2, 1. Verbal response goes from 5, 4, 3, 2, 1. Motor goes from 6, 5, 4, 3, 2, 1. So you check these 3 things. Okay, so you have to check first eye opening, best response. How do you check eye opening? If his eyes are open normally, like he's lying in the bed but his eyes are open, that will be best eye opening E4. His eyes are spontaneously open. आँख खुली है, यहाँ वहां देख रहा हूं. On the other hand, if his eyes are closed, so when you go to examine him, his eyes are shut. What will you do first? You will call out to him, "Hello, Siddharth, open your eyes. Siddharth, open your eyes." Siddharth will open his eyes. That is called as eye opening to verbal commands, E3. So, अगर मैं नाम पुकारूं और वो आँख खोले, that will be E3. But I call out to him, "Siddharth, open your eyes, open your eyes." He doesn't open his eyes. Then I give him a painful stimulus. Painful stimulus means I squeeze this muscle over here. That is called trapezius. उसको मैं चुंटी मार दूं. Or I rub his sternum. Or I press over here. Eyebrows पे. Orbital press. If I do that, and then in pain he opens his eyes, that will be E2. So eye opening on painful stimulus. Okay, but painful stimulus क्या होगा वो भी लिख लो आप. What is painful stimulus? Painful stimulus will normally be, you should squeeze the trapezius. Trapezius, you know, is the muscle over here, ये वाली muscle. That is trapezius. So you squeeze the trapezius. Or you rub the sternum. Or you are going to give orbital pressure. So these ways I can give some pressure. They are what are called as painful stimulant. तो मतलब सुई लेके टोचना मत उसको, ऐसे कुछ भी स्टिमुलस मत देना. These are defined stimuli. Okay, so totipotent, whatever your real name is, these are the defined stimuli. तो कायदे से आपको ये करना है. Okay, so this is how you come to know eye opening spontaneous, eye opening, "Hello, Siddharth, open your eyes," or Siddharth not opening his eyes, give him a sternal rub, he opens his eyes. And if ये सब करके भी उसने नहीं खोला, then there is no eye opening. So no eye opening is E1. Okay, it's not E0. It is E1. ठीक है, तो ये हो गई आई ओपनिंग, इजी टू चेक, 1 सेकंड में चेक कर लोगे. Now you have to check verbal response. So I asked Siddharth, "Hi Siddharth, how are you today?" He says, "I am good, sir. How about you?" That means he's having normal speech or he is oriented. So V5 is oriented. Please understand, अगर वो बड़बड़ कर रहा है अपने आप, that is not V5. V5 means I ask him a question, he gives the answer. That is going to be V5. Okay, so he is giving a oriented response and not a खाली बात करना, बकबक करना जो आप लोग करते हो, नींद आ रही है, नींद आ रही है. That is not V5. You are not in V5. On the other hand, when the class goes on for a little long and you are a little tired, and then I ask a question, and then suddenly you're like, "Sorry, what did you say? Come again." That is going to be V4. So V4 means confused. Means suddenly I woke you up, you don't know where you are answering, but you're not very sure. जो आपकी लाइफ में बहुत बार होता है, dicey. You are dicey. That is V4. फिर क्लास खत्म होती है और कुछ ऐसी चीजें होती है जो मैं नहीं पढ़ाता हूँ, जिसकी वजह से आपको गुस्सा आ जाता है. Then you start hurling abuses at me. ये नहीं पढ़ाया, लिम्फेडिमा नहीं पढ़ाया, गाली बक रहे हो, करेक्टली बक रहे हो, लेकिन गाली बक रहे हो. You are speaking inappropriate words. So please understand, खाली बातें करने का मतलब आप V5 नहीं हो. You should be oriented, which you are only when the class starts. All right. So that is going to be V3. Inappropriate words, hurling abuses, V3. In V2, that is when someone asks you for feedback when you are walking out of class and you're like, hop, hop, and you run away. एक शब्द भी नहीं बोला, हप हप करके चले गए. That is going to be V2. Or incomprehensible sounds. जो आप बाकी ऑफलाइन क्लास में नहीं करते हो, आई एम श्योर वहां तो आप 1-1, 2-2 मिनट के बड़े बड़े टेस्टिमोनियल देते हो. मेरी क्लास के बाद नहीं होता वो सब. मेरी क्लास के बाद लोग गुस्से में निकल जाते हैं, क्या पढ़ाया कम, डाटा ज्यादा, पढ़ाया कम, रोज ज्यादा किया, वो करके भाग जाते, या क्लास के बीच में भाग जाते, वो भी होता है. सो बट बाकी वो को टेस्टिमोनियल्स, 2-2 मिनट के टेस्टिमोनियल, बढ़िया. सो you can see your verbal response in my class versus the class of your favorite teachers. V2 only sounds, and V1, which most of you follow even when the class is on, you have no response. मैं किसको भी बुलाऊंगा जवाब नहीं आएगा, no response, right? So that's how you're going to remember. Again, V1 is no response. So oriented, confused, words, sounds, no response. ये हो गया आपका वर्बल भी अब थोड़ा थोड़ा समझ में आ गया. त्रास नको देव रे अभ्यास करा. अभ्यास नहीं करने, अभ्यास ही तो नहीं करने आए. अभ्यास करने वाले लोग ना अभ्यास कर लेते, उनको बोलना नहीं पड़ता. अभ्यास means to study. That's what Shama is writing. Okay. Now come to M6. The understanding of M6 is you are moving your hands about in the leg, in the bed. That is not M6. M6 means I ask you to raise your right hand and you raise your right hand. That is M6. So M6 is going to be when you obey commands. Okay. तो अगर आप गुस्से में आके अगल बगल वालों को लाफा वाफा मारो, that is not M6. If I tell you don't slap him, raise your right hand, and you do that, that is going to be M6. M5, 4, 3, they are a little different. To check M5, M4, M3, I have to give a painful stimulus. For example, trapezius squeeze. I squeeze the trapezius. In M5, you are going to do what is called as localize the pain. Localized pain means if I pinch you over here on your shoulder, what you're going to do is with the other hand, you will try to push my hand away. So where the painful stimulus is given, you try to push the stimulus away. That is localizing. Your hand is going towards the stimulus so that you defend yourself. It's a defensive टेक्निक कि अगर मैं आपको गाली बकूं एंड यू कर्स मी बैक, localizing pain. Okay, so if I say कि totipotent, please change your name, please bring your original name, and totipotent will say get the hell out of here, I'm not going to do it. He's localizing pain, like for like. On the other hand, M4 means I squeeze over here, instead of pushing my hand away, वो अपनी shoulder पीछे ले लेगा, so that he or she goes away from the painful stimulus. That is called as withdraws to pain. ये सब English words है. Localize means go towards the painful stimulus. Withdraws means go away from the painful stimulus. तो shoulder पीछे गई. So totipotent will just leave the class. Like मेरे को बात ही नहीं सुननी है, मैं चला गया. M3 and M2 are very exaggerated responses. Okay, in M3, what you do is when a painful stimulus is given, you don't just take the hand away, the whole body goes like a flexion attitude. So the whole body goes in flexion. That is called as abnormal flexion. Abnormal means पूरी की पूरी body flex हो जाएगी. मतलब मैं आपको एक चीज बोलूं, आप मुझे 50 गालियां दो, एक से भले 50, इतना magnified response. That is abnormal flexion. On the other hand, when my brain is basically not working, even if I do thoda bahut touch, thoda stimulus, the whole body goes in extension. That means practically there is no brain left. That is called as abnormal extension. Also called as decerebrate posturing. Decerebrate posture. And in M1, there is no response. Okay, I have spent some time to explain to you GCS for the simple reason is if they give you a question on calculate GCS, you cannot make a mistake. Okay, it is a bread and butter topic. इसमें mistake नहीं कर सकते. So obeys commands, raise your right hand. He raises right hand, M6. Pinch the shoulder, push away the stimulus, localizes pain. Pinch the shoulder, take the shoulder away, draws to pain. Pinch the shoulder, full body, not just shoulder, full body flexes, abnormal flexion. Pinch the shoulder, full body extends, not flex, extend, abnormal extension. Pinch the shoulder, nothing moves, nothing happens. M1, no response. Okay, are you very clear? तो मैंने 3 बार बताया ये. So to check 5, 4, 3, 2, you have to give a stimulus, painful stimulus, and see how he responds. I will ask one question further. If the person is intubated, okay, I have in the breathing part I put endotracheal tube, and obviously now he cannot speak because there is a tube in his mouth. So in that case, if any component cannot be checked, if I can't check any component, I will not write it as 0. I will write it as NT. NT means non-testable. So technically speaking, my GCS can be 0 also if everything is non-testable. If I can't check his verbal response, I will not write V1. So if he is intubated, I will not write V1. I will write verbal response NT. ऐसे छोटा सा suffix V NT. If eyes are bandaged because eyes are injured and you can't check eye opening, he will be NT. So whatever can't be checked will be NT. And the last thing, let's say there are 2 people here. One is Mr. Siddharth, and let's say Siddharth came with a head injury, and his GCS is, let's say, E3, V3, M3. And totipotent, his best friend, I won't know boyfriend, girlfriend, but totipotent, toti likha hai, has a GCS of E2, V3, M4. So दोनों का total GCS is 9. Are they both having the same prognosis? Are they both having the same pro? No. How? Same GCS. GCS is 9 by 15 in both. So prognosis is not the same. Okay. No, I don't know why you are saying no, but जिसने भी no बोला उसका आंसर सही है. If two people have the same GCS, you look at the motor response. Because the motor response is the best predictor of neurological outcome, which means totipotent has M4, Siddharth Chaudhary is M3. So totipotent has a better M score, so he or she has a better prognostic outcome. So this is the best predictor of outcome. So I hope you have realized there are so many things which can come as an MCQ on this topic. They can ask you blanket calculate GCS, they can ask you some component of GCS, or they can ask you some application of GCS. Then the next thing you are going to check, apart from the GCS, is you will check the pupils, and you will check how many pupils, means both pupils or single pupil, how many pupils don't react to light, unreactive. How many pupils don't react? So you will count how many pupils are non-reactive. So let's say both non-reactive. So you will give it as 2 points. Only one non-reactive, you will give it as 1 point. And if you see as none, means both are reactive, none are non-reactive. Dono mein reaction, it will be 0. Why I'm telling you this is, with this you can calculate what is called as GCS minus P score. Okay, ये minus है, minus GCS minus P score. So let's say Siddharth has GCS of 9 and he has only one pupil which is reactive, one is non-reactive. So GCS P score will be 9 minus 1 equal to 8. Okay, so this is how you can calculate GCS P, but it's actually GCS minus P. Alek has asked a brilliant question. Patient has a head injury and he has a stroke. Stroke nahi bol sakte. He has one-sided weakness. So let's say left side is completely paralyzed. Right side is working. So when I ask him to raise his right hand, he raises his right hand. But on the left side, he is not able to raise anything. Pinch karna to bhi movement nahi aa raha. So on left side, his motor response is M1. Right side, motor response is M6. What do I take it as? Right side M6, left side M1. You mentioned both. No. You count it as M6 because please remember, you check the best response. ये word मैंने इसलिए लिखा, best. So if you get two responses on different sides of the body, you count the higher one, not the lower one. Lower one nahi, higher one. You count the best response. Okay, answers your doubt. That's why it is best eye-opening, best verbal, best. GCSP normally is not used, but it is even more sensitive. अगर आपने pupil भी include कर लिया ना, तो it becomes even more sensitive. Suppose both E and V are non-testable, then what would जो लिखा है आपने ENT, VNT, M4 वैसे जो भी non-testable है उसके आगे NT. Okay, answer this. June 2021. So patient comes to RTA, he was intubated, he opens his eyes on verbal commands, which means he is E3. Opens eyes on verbal commands. Moves all four limbs spontaneously. Actually, it should be moves all four limbs on command. It should not be spontaneous, it should be on command. So this will be M6. And intubated means V is going to be non-testable. So E3, E3, VNT, M6. Answer is D. Okay, but I will again say this is not very correct. It should be he moves all four limbs on command. Okay, he should be moving it on command. That's better. ये terminology थोड़ी गलत है. After checking the GCS, तो ये हो गया disability. So you did airway, breathing, circulation, D for disability. After you check disability, the next thing you are going to check is going to be E for exposure. Exposure means you know what to do. Expose him means strip the patient or undress the patient. Why are you undressing him? Because you want to see any life-threatening external injury. Anything you can see from outside, which is life-threatening. So any life-threatening wound. Best example is if he has what is called as an open fracture. That is dangerous. Open fracture से bleeding हो सकती है. Or if he has some vascular injury. This has to be identified, and whatever you can do, you will do. If the vessel is bleeding, artery cut gayi, put some dressing on it, at least for the time being. If there is an open fracture, you splint the fracture. So that becomes your E. E is exposure. And the last is F. F stands for fast. Okay, fast का full form पता होना चाहिए. Fast is called as focused assessment by sonography in trauma. Okay, focused assessment by sonography in trauma. Focused means normally if any one of you has had an ultrasound of your abdomen, they check everything. They check your liver, gallbladder, kidneys, intestines, pancreas if they can see, uterus, bladder, prostate, सब कुछ देखते हैं. That is not focused. That is your normal ultrasound abdomen, which you and me undergo. In a trauma patient, I don't have the time to see everything. Okay, because this I am seeing in a primary survey, means patient can be unstable. So fast is something which is focused. It's a type of ultrasound. Basically ultrasound है पर focused है, सब जगह नहीं करना है, कुछ abdomen में करना है, means some areas of abdomen, and it is going to be done even if the patient is unstable. So it is kind of the MCQs, it is the investigation of choice in unstable patients with chest or abdominal trauma. Obviously head injury में करने की जरूरत नहीं, लेकिन अगर chest में या abdomen में trauma है and patient is unstable, you can do fast because it is done at bedside. So what is this fast? You do a quick ultrasound. It is done in the emergency room. Patient को आप कहीं लेके नहीं जाते हो. It is done at the bedside. And what the radiologist will do is he will look at 4 areas. Only 4. That's why focused. What are these 4 areas you can see? The first area that he will see is the epigastrium. But why is he looking at the epigastrium? यहाँ पे क्या देखता है वो? He is looking for pericardial fluid. Okay, he is looking for pericardial fluid. So, is there fluid around the heart? अगर patient को trauma है, and if he has fluid around the heart, that means obviously this fluid is blood. That is called as cardiac tamponade. Okay, please stop writing fast or e-fast. Okay, please relax. Your questions will get answered. पहले टॉपिक तो खत्म होने दो, पहले मत रट लगाओ फास्ट और ई-फास्ट, फास्ट और ई-फास्ट. बैठा हूं ना मैं इधर, चिल करो थोड़ा लाइफ में, सुन तो लो. So first you look at the epigastrium for pericardial fluid. Then you look at this area, that is the right flank. And what do you see in the right flank? You look for free fluid in the right flank. अभी ये free fluid क्या है मुझे नहीं पता. Is it blood? Is it bile? It can be anything. But I look for free fluid. अभी यहाँ पर free fluid क्यों आएगा trauma के patient में? Probably he has injury to the liver. Probably. Or he has injury to the right kidney. One of the two. कहीं से भी आ सकता है और मैं assume करूंगा it is one of those two. Next I'm going to see is the left flank. To look for free fluid. अब left flank में क्यों आएगा free fluid? So left flank में free fluid आया I will assume, okay, maybe it is coming from spleen, क्योंकि वहां पर spleen होती है, or it is coming from left kidney. And the fourth, I look over here in the pelvis. So the fourth zone that I see is going to be the pelvis. Why will he have free fluid in the pelvis? There are many reasons. It can come from anywhere. It can come from urinary bladder, maybe the bladder tore, or it can come from some other organ, any other organ in the body, like mesentery. Or it can come because of hollow viscous perforation, intestine got perforated, peritonitis, and so on and so forth. So what am I doing here? I am only looking for an ultrasound, very focused. Okay, this is highly selective vagotomy. Only those areas. I am not truncal vagotomy. Only those areas I am looking for free fluid. If I see free fluid in any of these areas, I will say fast is positive. बस यही देखना है मुझे. Fast positive, fast negative. Free fluid, no free fluid. Nothing else. No, same probe for all. Probes are not different. Now, since I am anyway seeing the abdomen, what they realized was 10-15 सेकंड और spend कर लो and also look at the chest. Also look at the thorax. So same time, also screen the chest. Same time. That is called as E-fast. E means extended, which means also screen the thorax. Why am I looking at the chest? To look for pneumothorax or to look for hemothorax. तो साइड बाय साइड देख लो, बात खत्म. तो आज के जमाने में फास्ट एंड ई फास्ट आर द सेम. ओके, उसी टाइम पे देख लो, काम खत्म करो. आई बात समझ में? सो when I do fast, I am only looking for presence or absence. I am not really looking for, oh, यहाँ पर ब्लड आया, कहाँ से आया, राइट किडनी से आया या लिवर से आया या इंटेस्टाइन से आया, ब्लड है या कुछ और है. I am not seeing all that. I am only looking presence or absence because this has to be done in a matter of a few minutes, not for a long time. Okay, 15-20 minute नहीं लगा सकते. Now, what is the problem with fast? Question comes on this. Drawbacks. What will fast not see? Yes, please tell drawbacks. And Dr. On, please tell me what previous question, one more time confusion, which option you had problem in, which question was this? Was it this question? Which option is a problem? He's moving all 4 limbs on command, will be M6, normal movement. He's intubated, verbal response will be non-testable. And opens his eyes on verbal command, that is E3. यहाँ से आया. Opens his eyes on verbal commands, E3. So GCS will be E3, VNT, M6. वही तो था. Okay. कुछ मिले ड्रॉबैक? एक दो तो मैंने बता दिए. Very good options, good answers. Many of you have written nice things. So the main problem is, first is that it is dependent on who is doing it. A good sonologist will pick up many things. A bad sonologist may not pick up many things. So it is operator dependent. Okay. अभी जो आपको सोनोलॉजिस्ट बोलेगा आपको बिलीव करना पड़ेगा. It is operator dependent. It can detect only fluid if it is more than 100 ml. So if the fluid is less than 100 ml, it may be missed. तो उसको ब्लीडिंग हुई है लेकिन पता नहीं चला क्योंकि इतना फास्ट में 100 ml से कम फ्लूइड मिस हो गई. It will not tell what is the fluid. Means, is the fluid blood? Is the fluid bile? Is the fluid feces? Nature of fluid नहीं पता चलेगा. It may miss pneumoperitoneum. So if the person has a stab and the intestine perforated and there is air under the diaphragm, it may miss it. That is best seen on X-ray. So it may miss free air or pneumoperitoneum. It may miss retroperitoneal bleeding. because retroperitoneum is not well seen. So retroperitoneal blood वगैरह उसको नहीं दिखेगा. So these are some of the drawbacks. So they can ask you all of these are seen on fast or e-fast except. So उसमें one of these will be the except. Okay, this question was asked in INI CET a few years back. But yeah, now it can come in your exam also. Even less than 100 ml fluid can kill. It can increase later ना. अभी जब आपने देखा तो पता ही नहीं चला. Maybe it was 80 ml. You checked it only once. And after few hours 80 ml became 800 ml. But वापस आपने फास्ट नहीं किया ना. तो पहले तो मिस हो गया. ठीक है. So these are the drawbacks. It's not very reliable, but yeah, it can be done in an unstable patient. ये सब A, B, C, D, E, F कर दिया ना आपने. अब आपका aim क्या है? Your aim is at the end of primary survey. What is the aim of primary survey? What is your target? ये सब A, B, C, D, E, F करके. Very good. The patient should become stable. At the end of primary survey, patient should become stable. He should be stabilized. There are some things that you may do along with primary survey, which are called as adjuncts. Okay, answer this before we go. Before we go to the next step. Answer this. So 25-year-old male, history of RTA, suspect injury to the chest and abdomen. His systolic BP is 70 mm of H. That means he is unstable. Unstable patient, you will do fast. Okay. CCT will be done only when patient is stable. तो इस पेशेंट में आईवी फ्लूइड देके एक बार वो ठीक हो गया, आपने फास्ट कर दिया, आगे बढ़ोगे तब सीटी. अनस्टेबल पेशेंट में सीटी नहीं है. Answer this. Which of these is not done in primary survey? Okay, easy question. Performing CT. CT is not done in primary survey. CT is done in secondary survey. चलो आगे बढ़े. गुड. इतने ये सारे क्वेश्चन जो पूछते हैं ना बच्चे, इसमें भी मिस्टेक कर. इफ स्टेबल ऑलवेज सीटी और फास्ट. स्टेबलाइज तो आप प्राइमरी सर्वे में करोगे, तो फास्ट तो कर लिया है. एक बार स्टेबलाइज हो गया तब सीटी करोगे. This question was an interesting one. Patient comes to the emergency department with severe, ये अभी वाले एग्जाम में आया just now, severe maxillofacial trauma. Airway is obstructed and you have to do something immediately. What is the most appropriate immediate management? Immediate management. So people fought with me a lot, but my answer would be immediate intervention, go for cricothyroid. Okay, orotracheal intubation and jaw thrust cannot be done when there is oromaxillofacial trauma. So between these two, go for cricothyrotomy. Tracheostomy will be the definitive management. Okay, एक दो वर्ड इन्होंने चेंज कर दिया ना, आंसर चेंज हो जाएगा इसमें. So be a little cautioned about this, about the choice of words that they are going to give you. If they ask you most appropriate, immediate, or next step, go for cricothyrotomy. Okay, most appropriate, immediate. If they ask you most appropriate, सिर्फ इतना ही है. If this immediate word is not there, ना, if you remove the word immediate, then go for tracheostomy. Okay, so two answers can be correct here with a few change of words. Get this concept. Many times, along with primary survey, you can do some extra things. They are called adjuncts. These are the things which may be done. मतलब सारे पेशेंट में आपको करने की जरूरत नहीं है. So when you are doing the A, B, C, D, E, F, these are some of the components you may do if required. Okay, you may do if required, वरना जरूरत नहीं है. So what are these things? You can do chest X-ray, but when you do chest X-ray, it should be done in AP view. आप में से किसी ने chest X-ray कराई है अपनी? Has anyone had a chest X-ray done? Have you ever experienced it? I get all my scans done every year. So when you do chest X-ray, it is done PA view. वो कैसे करते हैं ना वो? You have to stand, you have to hold the plate like this, you have to hug it, and the machine is behind you. So you have to stand to do chest X-ray in PA view. But trauma patient, don't make him stand. Trauma patient will be supine. Supine will be AP. Okay, so be watchful for this. One of the options will be chest X-ray PA view. That is incorrect. खड़ा नहीं कर सकते patient को. You can do X-ray cervical spine. So this will help you identify cervical spine injury. But obviously, you have already put the collar. So collar लगा दी, X-ray कराया. If it's all fine, you can remove the collar. Some blood tests can be done. Pulse oximetry and ECG can be done. You can put a Foley's catheter. When will you not put? When is it contraindicated? And you can put a Ryle's tube. When is Ryle's tube contraindicated? ये दोनों चीज पता होनी चाहिए. Because trauma में patient will not tell you क्या फूटा है. You have to identify क्या फूटा है. Bleeding, कौन सी bleeding? So you will not put a catheter, Foley's catheter, if you see blood at meatus. Okay, if you see blood at urethral meatus present, that means urethra is ruptured. Don't put catheter. When will you not put Ryle's tube? Ryle's tube will not be put. Don't say CSF leak. Patient नहीं बोलेगा ना उसको CSF leak है. वो नहीं बताएगा उसको CSF leak है. If he has watery discharge from his nose. If there is a serious discharge coming from his nose, that means maybe he has a CSF injury or CSF rhinorrhea. ठीक है? So these are the places where you will not obviously put a Ryle's tube or a Foley's catheter. Reason is if he has CSF coming from his nose, there is a bone behind the nose which is called cribriform plate that may have fractured. तभी तो CSF leak हो रहा है. And if you try to put the Ryle's tube, it can go through the cribriform plate, and you know where it will go from the cribriform plate. दिमाग के अंदर. So it can go into your brain. So obviously you're not going to do it. Yeah. ये सब करके now your patient is stable, and now you move on to the next step, which is called as secondary survey. So secondary survey is going to be done after stabilizing. And what do I do in secondary survey? That's very easy. I do two things. First thing is I take a detailed history. क्या लेंगे हम history में? There is a mnemonic for this. It is called AMPLE. Okay. AMPLE means A for allergy. So you ask, does the patient have any drug allergy, any food allergy, any medical history? M stands for patient on any medications. Is he on any blood thinners? Is he on any diabetes medicines? P is for past illness. Did he have stroke? Did he have any GI surgery? Anything, any kind of a past illness. L is for when did he have his last meal? Last time khana kab khaya? Last time pani kab piye? Because if you have to give anesthesia, you want to know how much is he starving. If he is not starving a lot, अभी होटल से खाना खा के निकला और एक्सीडेंट हो गया, starvation may not be good, so you may be at an anesthesia risk if the person has to be operated. E stands for events leading to accident. Yeah, events leading to injury. Right. So you ask this kind of history. Events leading to माने क्या हुआ, कहाँ से गिरा, किसने मारा, गर्लफ्रेंड ने मारा, वाइफ ने मारा, किसने पीटा, was it a fast moving vehicle, cricket ball लगा, all that history you will elicit. Right. जब भी मैं बोलता हूँ ना गर्लफ्रेंड ने मारा, ये अनमोल और निखिल को बहुत हंसी आती है. I don't know, are they speaking out of past experiences, dangerous experiences? After taking this history, maybe yeah, सब उनकी पोल खुल रही है. जीएफ क्यों मारेगी? ये गलत पूछा आपने. आस्था, यू शुड से जीएफ क्यों नहीं मारेगी? क्यों नहीं मारेगी? Yeah. So this is your history. गर्लफ्रेंड के साथ भी ऐसी कमेंट मारते होंगे जैसे मेरे साथ मार रहे हैं, और क्या? सेम ही रीजन है, जो यहाँ करेंगे वही वहां भी करेंगे। ये आप लोग अश्लील चीजें मत लिखो प्लीज, डोंट राइट प्रेगनेंसी सैडिज्म, ये सब मत लिखो। ये सर्जरी क्लास है, फोरेंसिक क्लास नहीं है ये सब ना। सो यू आस्क दिस हिस्ट्री and then you do a detailed examination because now you want to know कहाँ कहाँ मार पड़ी, कहाँ कहाँ इंजरी हुई है। So you do a detailed head to toe examination. After this, you will do further investigations, whatever is required. This is where you can do CT scan. There are other tests also. You can do certain endoscopies, वगैरह वगैरह, but normally in trauma you do CT scan. And after this, you will do the definitive treatment. ठीक है, आगे बात समझ में? सिंपल। तो क्या शुरू करें हमने? First you did airway. How did you come to know airway is blocked? Asked him to speak. Immobilize cervical spine, secure an airway. Then you check breathing, respiratory system, cardiac system. So all that you check. Then you check circulation. 2 large IV lines, IV fluids, vitals, tranexamic acid. Then you check GCS and pupils, visibility. How much is GCS? Is there an intracranial injury? Then you expose. Strip the patient. Does he have any fracture? Does he have any bleeding somewhere? Stop the bleeding. Fix the fracture. And then you do fast. Fast will be done if he's unstable or if he has chest or abdominal injury. Check the four areas. You can check the lungs also if you want. Only to know is there free fluid or not. Side by side, do some adjuncts. If need be, these adjuncts are going to be done side by side. Some X-ray, ECG, वगैरह वगैरह. After he is stabilized, detailed history, detailed examination, detailed investigations. Okay. तो कभी लाइफ में आंखों के सामने किसी को ट्रॉमा हुआ हो, इस प्रकार से आप मैनेज करो। Okay. Why 2 IV lines? Because you may have to give him a lot of fluids. एक ही IV लाइन से 1 लीटर फुल फ्लूइड बोलस देना मुश्किल होगा, तो दोनों आधा आधा करके दोगे। Now come to इस पे से 100% you will get one question, one MCQ, sure shot. Oh, I should not use that word sure shot. One MCQ certainly. ये sure shot बोलना थोड़ा it can be patented. Log roll, अच्छा हाँ, okay. Log roll आपको बताता हूँ. Good, you asked that question. When I do this head to toe examination, when I want to see the back of the patient, I have to turn the patient. This turning the patient is what is called as log roll maneuver. Basically, log roll requires 4 people. एक आदमी से नहीं होगा, 4 लोग लगेंगे. One person will hold the head and neck. One person will hold the chest and abdomen. One person will hold the legs. So 3 people will turn the patient at the same time. It should not be एक आदमी ने गर्दन घुमा दी, एक आदमी ने छाती पकड़ के रखी. All 3 have to go. जैसे एक बड़ा सा log of wood को रोल करोगे, वैसे इंसान को रोल करना. 4 people have to be done, are required to roll the person, and it is basically to examine the back. Any injury to the vertebral column. So back देखने के लिए मुझे log roll लगती है. So 3 people will turn the patient at the same time. One is holding the head and neck, one is holding the chest, shoulders, one is holding the legs. They turn him, and the 4th person will check, is there any injury to the back? Okay, that is called as log roll, right? So that is going to be done in secondary survey. Yeah, minimum 4 people. Minimum 4. Now come to head injury. When we think of head injury, we will always think of brain injury. But let's be very clear, head means everything around here. Okay, it's not only the brain inside it. Some of us don't even have that. Some of us head injury means only outside. But practically speaking, when I say head injury, it has 3 parts. The first part is the scalp and the superficial wounds. So this will include lacerations, bruises, incised wounds, and so on and so forth. So whatever wounds I get on the face, on the scalp, all that will come in superficial injuries. तो अगर यहाँ पे कट भी लग गया ना, it comes under head injury only. Then I go inside on the bone. So your skull bone has different parts which can get fractured. So you can get a fracture of the skull bones, like the skull vault or the facial bones, maxilla, mandible. They can fracture, or you can get a fracture of the base of the skull. Okay, on which the brain is sitting. That is called base of skull. So you can get base of skull fracture. What are the parts of base of skull? Base of skull में क्या क्या आता है? And I say base of skull is fractured on which the brain is sitting. What is all that called? Yeah, very good. So anterior, middle, posterior knee, they are called the fossa. You have the anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. So there are these three parts of these fossa: anterior, middle, posterior cranial fossa. They can fracture. So the bones can fracture over here. They can fracture on the face. They can fracture on the base. Okay. The third area of injury is inside the bones or inside the skull. They are called the intracranial injuries. Inside the skull. Intracranial, maybe there are two parts. The first part is what is called as extracerebral. Okay, they are called as extracerebral. Extracerebral means brain के बाहर. इसके अंदर come your important ones, your EDH, जो हम डिस्कस करेंगे, SDH, epidural hematoma, subdural hematoma, subarachnoid hemorrhage, SAH, intraventricular hemorrhage. All of these come, they are technically outside the brain parenchyma. And then you have, which is something truly in the brain, which is called as intracerebral. What is intracerebral, or rather what comes in intracerebral? Which are truly injuring the brain parenchyma. Actually तुम्हारे दिमाग पे जब इंजरी हो. Yes, concussion. Any other? Contusion. Very good. So you heard the terms. You have a concussion. You have a contusion. You have a diffuse axonal injury. Okay, concussion, contusion, diffuse axonal injury, also called as DAI. We will discuss all of them. इसमें जो important है, जो surgery में आते हैं, medicine में कुछ अलग है. जो surgery में आते हैं, those are these: EDH, SDH, थोड़ा बहुत concussion, contusion, and DAI. They are the important ones. एकदम conceptually समझेंगे ना, इसमें आपको कोई भी question if they ask you, how much ever they will twist, you will be ready with the answer. They are all very conceptual topics, very interesting topics. ऐसे रट्टाबाजी की इसमें जरूरत नहीं, ठीक है? तो ये करेंगे सारे. या अंकित ने दे दी मुझे रट्टा वाला आंसर, दे दिया अंकित ने. इडली EDH. ये इडली EDH में ही ना, in last year's NEET PG there was a CT image. They could not understand was it idli EDH or was it banana or whatever, and people made a mistake for this very reason. This reason it came last year in NEET PG. ये सोचे थे, if it looks like an idli I will call it EDH. For NEET PG वालों ने googly डाल दी. Okay, so I'll tell you what googly will come. But first and foremost, let's start with some of the other injuries, the easier ones, which are very classical. Some fractures. What is this? What do you see here? This has been asked quite a few times in a lot of entrances. So this is seen in what is called as fracture of anterior cranial fossa. This appearance is called as raccoon eyes, also called as panda eyes. You know what is a panda? India में तो नहीं है, but in some of the FMG students say where they are studying, they have panda. Yeah, China, Hong Kong में होता है. इंडिया में नहीं होता है panda. So These kind of eyes are seen when the base of the skull is fractured anterior cranial fossa fracture. This person is also likely to have leakage of CSF from his nose. That is called as CSF rhinorrhea. Second image, bata. What is this image? And where do you see this? This bruise that you see in front of the mastoid bone. This is called as battle sign. And this is going to be seen in fracture of middle cranial fossa. Normally, can also be seen in posterior cranial fossa. This is called as battle sign. What other feature do you see in MCF fracture apart from battle sign? Very good, excellent. Here you will see CSF coming from his ears. You will see CSF autoria. Very good. So these are some of the findings you will get in bone injuries. If facial bones are fractured, you will see bruises over here, you will see tenderness, वगैरह वगैरह. X-ray पे दिख जाएगा आपको fracture. See, 2 times this question came. It also came in NEET PG, this question. चाइना का नेशनल एनिमल है पैंडा, बढ़िया. इंडिया का नेशनल एनिमल क्या है? What is the national animal of India? Tiger, lion. Tiger सही नहीं है. It means it's not the correct name. It's incomplete. पता नहीं है आपको ना. चाइना का नेशनल एनिमल पता है, इंडिया का नेशनल एनिमल का आधा ही नाम पता है. या रॉयल बंगाल टाइगर. आई थिंक आपने गूगल सर्च किया होगा. आई डोंट ट्रस्ट यू. यू मस्ट हैव गूगल्ड इट. सर पोपट कर देंगे नहीं तो. एनीवेज, इसका आंसर है battle sign, which is seen in middle of posterior cranial fossa fracture. Now come to your favorite, E for Idli. This image was asked 2-3 times, and abhi wale FMG Jan 2024 maybe something similar was asked. So I'll tell you what mistake you will make in your life. I'm talking about EDH. EDH means extradural hematoma. Who gets extradural hematoma? Or rather, what injury will give you extradural hematoma? कौन सी इंजरी से होता है? स्कल. स्कल कोई इंजरी हुई है? ये कौन सी इंजरी है? MMA is the structure which will tear. Let's say there are 2 persons. One was a Formula 1 driver and he had a car accident at 200 kilometers per hour and he got a head injury. Second is someone who's playing cricket and the season ball hit his head over here. Who will get it? First patient or second patient? Both. No, both will not get it. This will normally happen after a moderate intensity trauma. Okay, this normally happens after moderate intensity trauma. Normally. So a moderate intensity trauma, especially on this bone over here, it's a very thin bone, petrous temporal bone. When like a season ball hits over here, this bone will break, and just underneath the bone, the middle meningeal artery will tear. So there is a tear of MMA. There is a tear of middle meningeal artery. This artery is present between the dura and the skull. So if my skull is like this, underneath the skull is the dura mater, and dura mater में ऐसे चिपकी होती है. So dura mater, and inside the dura mater is your brain, like this. So this will happen because of a tear over here in the MMA over here, and because the dura is stuck to the skull, the clot cannot spread. दूर नहीं जा सकता. It cannot spread. It will only be here, and it will grow like this, and it will grow like this. That's why it will have a shape like this, like an idli, because the dura is stuck. So when the bleeding happens between the dura and the skull, the dura can only be a little bent. Blood cannot spread. So this will always have a appearance of this kind, which you will call as E for Italy. I would not call that. But before we go to the appearance, how does the person present? Typically, or rather, what typical finding do you get in this patient? So the clinical presentation is very typical, which I have written over there. What is that? Lucid interval. क्या होता है lucid interval में? सब लिख रहे हैं lucid interval. Lucid interval is seen only in EDH or it can be seen in other head injuries also. Consciousness between two unconsciousness. Conscious, unconscious, conscious. Okay. So let's see what happens here. The typical presentation will be, the patient will say, first I got hit with the ball and then I was unconscious for short time. Unconsciousness, maybe for 10 minutes, 10-15 minutes. Then he will say, after those 10-15 minutes passed, I was normal. I became okay. He was absolutely normal. This normal period, it can last again for 15-20 minutes, maybe a little more. This is called as lucid interval. But he will say that after that, again after 15-20 minutes, I became unconscious again. So what has happened here is, when he got hit, momentarily for a few minutes he was unconscious. Then he woke up. Pani piya usne. He felt ठीक है, कुछ नहीं हुआ. I'm okay. I'm all right. I'm feeling better. He went about, but then unconscious again. This period of consciousness, of normal consciousness between two periods of unconsciousness, is called as lucid interval. So when the ball hit him, he fainted, he was unconscious, then he woke up, he was all right for some time, and then he collapsed again. That is called as lucid interval. ये क्या ऐसे अजीब अजीब ये क्यों हुआ ऐसे? जब हिट हुआ तभी से अनकॉन्शियस होना चाहिए था. ये बीच में ठीक क्यों हुआ? Why did he become all right in between? वही तो मैं पूछ रहा हूँ श्रेष्ठा. ऐसे कैसे हुआ? जब चोट लगी, why did he become all right for some time? Yeah, interval can be up to 1 hour. It's variable. The period is variable. No, it's not due to clots. ऐसा नहीं है. Artery only bleeds. No, see. The first time he got hit, the first unconsciousness was because of a phenomena which is called as a concussion injury. जब चोट लगी, maybe the artery tore, but it must not have bled very fast. 2-3 ml blood गया होगा initially. That will not make him unconscious. He was unconscious because of an event called as a concussion, which happens in sports very often. अगर सर पे ज्यादा जोर से चोट लग जाए, आप 5-10 मिनट के लिए कोलैप्स हो जाते हो, फेंट हो जाता है. It's called a concussion injury. But you always recover from it. So you get a concussion, you recover, but you don't know na artery was torn. Slowly, artery will bleed. But he's all right now. Once the artery bleeds enough, it will start compressing the brain and he will become unconscious again. This is because of the clot causing the increased in intracranial pressure. This is the actual effect of the extradural hemorrhage. So the first unconsciousness is not because of the EDH, क्योंकि तभी तो bleeding सिर्फ शुरू हुई है. The first time he becomes unconscious is because of something called as a concussion injury, which is temporary. Eventually, once the clot will grow fully, it will cause a raised ICP, and then he will become unconscious. This is typical of extradural hemorrhage. Apart from this, he can have other features also. Apart from this typical history, the clot by itself can cause vomiting because of raised ICP. Or he can have convulsions also, because there is a clot in the brain eventually. But they will be a little late because they require the intracranial pressure to rise. When I was a surgery resident, I was in first year. I remember very clearly that there were 4 or 5 boys who had brought their friend, young man. Young means younger than you. He must be 15-17 years old. And when he came, he was ekdam fine. He said, I got hit on the head. Kisne mujhe mara with some bat or something. and थोड़ी देर के लिए मैं बेहोश था, but now I'm fine, no problem. Then I examined him. His GCS was 15/15, no problem. All testing एकदम सही थी. I said ठीक है, थोड़ी बहुत चोट लगी होगी, ये मेडिसिन ले लो, जाओ. He went. Within half an hour, his friends brought him back on a wheelchair and he was having convulsions. I was like, shit, what the hell happened? When he came, he was fine. And now within half an hour, he's come back with convulsions. Then obviously we did CT scan and he had an EDH. So what mistake I made was I sent him home without observing him, without doing any CT. Which is why I missed. When he came, he was in lucid interval. If this was happening in a private hospital, I would have gotten, but because I worked in a government hospital and of course it's a teaching institute, so I was not screwed so much. Of course, I got scoldings a lot, but then this is how, you keep thinking, NEET में rank आ गई, rank आ गई, rank आ गई. मेरी भी NEET में rank आई थी, first attempt में आई थी. I did my MS from one of the premier institutes of Mumbai. क्या फायदा? At that time I didn't know that it was lucid interval. वो सूझा ही नहीं. और हमारे टाइम पे ऐसे MCQ नहीं होते थे. It was not computer based. It was, you had to mark circles. So these are the kind of things you will mess up in your residency, maybe in your real life, because your fundamentals are not clear. My fundamentals became clearer much later. हमारे टाइम पे भी पढ़ाने वाले भी नहीं थे. We only had books. You have hundreds of apps and thousands of teachers. We only had MCQ books of Amit Ashish, Mudit Khanna. Some of these people I have met in my life. खाली वो बुक्स पढ़ देते हैं और कुछ नहीं. से जितना समझा. तो हम no, he was saved. Eventually, he required surgery for his ADH. Eventually. Anyways, so you have to be aware of this kind of a history. Any patient who comes with this kind of a history, after you're done with the examination, the next step is you're going to stabilize him and you will do a plain CT brain. You have to do a plain CT brain. And on plain CT brain, you will see this, your favorite E for idli. Now, E for idli QA, you know why. It's because the dura is stuck. So the clot will always take a shape like this. The clot cannot spread too much. So it can only spread inwards. So you get a clot like this in the shape of idli. But it will always be a fresh clot. Fresh means white or hyper dense. So what you will see will be a white clot. So plain CT brain will show a white, or CT की भाषा में it is called as hyperdense. Like how X-ray में you say radio opaque, radio lucent. CT में you will say hyperdense, hypodense. Hyperdense means white. And it will be biconvex. Biconvex like idli. Yes. EDH will always be white. Means it will always be acute. You can never get a chronic EDH. It will only be acute because it happens because of arterial bleed. It will present immediately. And if you get a CT like this, what you are going to do next is you will have to do a urgent decompression. Decompression means remove the clot, surgically remove the clot. You can do it by making burr holes. तो छोटे-छोटे hole करके clot निकाल सकते हो. Or you can remove the clot by removing a part of the skull. That is called as craniotomy. But in EDH, most of the times, since it's an arterial bleed, you will have to do a decompression. You have to remove the clot. Otherwise, the brain will get compressed, the clot will keep growing, and he will have raised ICP and he will die. Within how much time, ideally, should you do the decompression? Within how much time, ideally, should you do the decompression? ASAP. Within 4 hours, within 1 hour, within 6 hours. So ideally, it should be done within 1 hour. 1 hour of injury. So आप पूछ रहे हो ना lucid interval कितना टाइम होगा? Normally ये सारा कार्यक्रम 1 घंटे में निपट जाता. Normally, 1 hour, 1 to 2 hours maximum, because it's an arterial bleed. So it's not going to take its own sweet time. Either you decompress or patient is dead. So I was lucky the patient didn't go too far. He was close enough that he came back in the time when he got convulsions and we could quickly do the decompression. So ideally should be done within 1 hour. This is called as, from this they came up with a terminology called as golden hour of trauma. अगर आप कुछ कुछ books पढ़ोगे ना, they will give these things, golden hour of trauma, that trauma should be treated within 1 hour. This golden hour phenomena was identified in EDH. Airway obstruction में नहीं होता है golden hour. Airway obstruction are golden minutes. आपको minutes में सब ठीक करना होता है. EDH within 1 hour it should be decompressed, which means identification, CT scan, OT, anesthesia, per hole or craniotomy. नहीं सीटी से पहले नहीं यशवंत, सीटी करना पड़ता है सब फटाफट. यू डोंट हैव सो मच टाइम. आइडियली 1 आवर, 1 घंटे का 2 घंटा हुआ तो भी ठीक है, पर 1 घंटे का 5 घंटा नहीं लगा सकते, अदरवाइज गेम ओवर. ओके, इट्स नॉट सो हार्ड एंड फास्ट. आई एम जस्ट सेइंग ideally within 1 hour. For temporary means once you make the hole, the blood gets drained. If it's still bleeding, then you have to open the skull more, which is called craniotomy, and then you have to suture the bleeding. So EDH mein most of the times you need to do craniotomy, most of the times, because you have to open the skull, see where it is bleeding and stitch it. But ideally within 1 hour. I'm saying ideal, so please don't say if he comes after 1 hour then what. ऐसा कुछ नहीं है, ऐसा जरूरी नहीं है. Doesn't cross suture means the clot, I told you, the dura is stuck. It is stuck to the suture, stuck to the suture, stuck to the suture. So the clot will not spread beyond a certain point. It will not go till here. It will not go till here. Itna spread nahi hoga. It will be limited in the space. It will spread more like this, not along the length. That is called limited to suture because the dura is stuck to the suture. But my message is, it will be a white edema. Okay, it will always be white. It will never be black. Where will it be black? I will tell you in some time. But this is about EDH. What can be done in patient arrives in lucid interval? That's not the question. If patient comes with head injury and you examine the patient and you feel that there is a risk of EDH, you should observe and do CT because it's likely that he may be in lucid interval. So that was about EDH. Now come to the next one, little more dangerous, that is called SDH. SDH stands for subdural hematoma or subdural hemorrhage. Now same way, who gets SDH? SDH will happen not after ball lagna, girlfriend ki se pitai hona. That will not cause SDH. SDH will require severe trauma, high velocity trauma, like a road traffic accident. So someone who has a road traffic accident is likely to get SDH. Okay, likely to get SDH, subdural bleed. In subdural bleed, what will bleed are called as cortical bridging veins. So the source of bleeding are what are called as cortical bridging veins. Now, what are these veins? I will tell you. Then you will clearly understand what SDH is. Very easy to understand. All fundamentals. ये 2-3 concept ही है इसमें. So think of it like this. Let's say this is your skull, and inside your skull is your dura, which I told you is attached in few places. Okay, in EDH the bleeding was here, above the dura, extra dural. Now underneath the dura you have some more layers, forget about those layers, and then you have the brain. Okay, there are some more layers, but let's not worry about them. From the brain you have these veins which are connected to the dura like this. They are called as the cortical bridging veins. Bridging means they are connecting the cortex of the brain to the dura. That's why cortical bridging veins. when there will be a very high velocity trauma, what will happen is the brain will move like this inside the skull. ऐसे वो हिलेगा. And because it moves like this, the veins will tear. So more than the artery tearing, more veins will tear because the brain will shear. So the veins will get sheared. 4-5 vein फट जाएगी. And when these veins will tear, he will have a bleeding over here in this plane, subdural plane. And because this plane is below the dura, and the dura is not going to be stuck to the brain, the blood can spread easily like this. So more than it spreading inwards like EDH, it spread along the brain as you see over here. That's why you will get a banana SDH. Are you not समझ में? So because it is subdural, it will spread along the brain. All right? That is going to be subdural. Okay. So how will the person present clinically when he gets a bleed like this? Now understand, person who has a road traffic accident will have a very bad injury to the brain. So when the injury happens, he will be unconscious. Okay. And he will likely to remain unconscious. His consciousness may improve a little bit, but he will never become lucid. ओके लूसिड नहीं होगा, मतलब एकदम सही कभी नहीं होगा, ऊपर नीचे हो सकता है एज द क्लॉट विल ग्रो, but he will never be lucid. So there is no lucid interval. That's what I want you to understand. So there may be up and down of consciousness and unconsciousness, up and down. Like he got concussion, he was unconscious, he improved a little bit, but he will never be conscious again. Right? So there will be no lucid interval. If there is no lucid interval, this cannot be EDH. Now come to what else will you get? You may get features of raised ICP. Obviously, patient with head injury with unconsciousness, what will you do? First you will stabilize, then you will again do plain CT. And what will plain CT show you? It will show you a banana shape or concavo convex. So it can be banana shape or concavo convex. Again, this will be white or hyperdense. So this tells you it is acute SDH. White blood means fresh blood. Fresh blood means acute. Right. So this is how you will get an acute SDH. How will you treat it? You will have to do same decompression. Now, why am I so white, hyper, acute? Because your SDH hota hai na, it can happen even without trauma sometimes. So sometimes you can get what is called as a chronic SDH or a subacute SDH. This happens in elderly people, senior citizens, not like you, not like me, much senior than me. Because in those people, the problem is the brain is very thinned out. The brain is atrophied. जैसे आप लोग का दिमाग ऑलरेडी हो रहा है, उनका तो उम्र के साथ होता है. So the brain has shrunken. Because the brain has shrunken, these veins are already very stretched. तो वेन खिंची हुई है, तो कभी कभार they will spontaneously rupture or rupture with a little bit of trauma. Mild trauma, bathroom में गिर गया, and one of the veins will rupture. That will give chronic SDH. So because the brain is atrophied, even after trivial trauma, there can be SDH. And this SDH will develop slowly. This will develop over weeks. So it will be an elderly patient who will say, मैं bathroom में गिर गया था. Then slowly he will say, थोड़ा मेरी याददाश्त जाने लगी, or I started losing balance, I started getting vomiting, some focal neurological deficit, raised ICT, these kind of features will appear. Okay. In this case, when you will do CT, since it is chronic, you will get SISDH, but it will not be acute. So it will not be white. It will be either gray or black. which means it will be hypotenuse. Because the clot will develop slowly. It will bleed, stop. Little more bleed, stop. It will happen over days to weeks. So when you will do a CT, you will get a dark looking blood clot, not as a white. Only SDH can be chronic. So if you get the question that was asked in NEET PG last year, they had given history of trauma 2 weeks back, and they had given a CT scan, and they had asked a diagnosis, and it looked like an idli. Unfortunately, it looked like an idli. The image looked like an idli. So people marked EDH saying, "Arey, ekdam idli, just like you guys did." Start में. But 2 weeks back में EDH हो ही नहीं सकता, because the blood would have gone by now, or patient would have gone by now. He will not come after 2 weeks with EDH. He will come at the same time. SDH can come later. आई बात समझ में? ये मिस्टेक मत करना. This is common sense answer and fundamental. इडली का डोसा नहीं, इडली ही. दिमाग खराब हो गया पेशेंट का भी और एग्जाम वालों का भी. So this can happen even without a grave trauma. Okay, it requires trivial trauma, and इसका treatment will also be decompression. So basically, 100 बात की एक बात, if they give you head injury with a blood clot, go for decompression. Don't worry about midline shift there or not. That's not that important. सीधा सीधा go for shape. कोई भी नहीं, shape तो यही होगी ना, shape तो ऐसी होगी क्योंकि वो subdural है. So it will look like this, but the problem is the images in the exam are not very clear. You cannot rely on the image to give you the answer. What you will rely on is the history to give you the answer, because images can be misleading. The eyes will, जो सब हमेशा दिखता है वो होता नहीं, लेकिन जो आपको पता है वो ही होगा. That's the difference. So don't believe what you see. Oh, okay, yeah, okay. ठीक है. A few traumas that we didn't discuss. One was called concussion. Someone was asking what is concussion. In concussion, it's a temporary event. So there is a temporary loss of consciousness. This happens to cricketers, footballers very often. So temporary loss of consciousness. If you do CT, it will be normal. So there is no clot, there is no EDH, SDH, nothing. It's just temporary. When you get hit hard, for a few minutes you will be unconscious, then you will be fine. Problem is, I don't know if this unconsciousness is the precursor to EDH in the making, which is what I thought. I thought कि इसको concussion हुआ है वो लड़के को, पता नहीं चलता. मैंने concussion समझ के भेज दिया उसको, निकला उसका EDH. That's why now in sports, if you get a concussion, they don't let you continue, because they realized it could be lucid interval. It can be early stage of EDH. So if you come with a concussion, you have to do CT to rule out EDH. That's what I was trying to tell before. What to do if patient comes in lucid interval, rule out EDH. If CT is normal, concussion, CT shows EDH. Clear? Are we clear with this? The other thing that can happen is you can get a contusion. Contusion simply means clot inside the brain. ये अपने आप नहीं होता. This normally happens along with EDH. So someone who gets EDH many times will also have a clot in the brain. So this happens along with SDH. तो जब इतना जोर से गाड़ी ने ठोका, SDH तो हुआ ही, brain also got injured, you got a clot inside the brain. And the third one is diffuse axonal injury, DAI. This happens after severe trauma. Bad accident, severe trauma. When the patient is completely unconscious, his GCS is very low, like GCS will be 5/15 or 6/15. बाकी सारे trauma में ना it is 10, 11, 12. Your GCS will be 8, 7, 6, 5. Very poor GCS. But CT scan, strangely, will be normal. You will think, is the patient lying? Is he faking illness? But no, CT is normal. In this case, the diagnosis will be confirmed on MRI. And what will MRI show? It will show some hemorrhages. So trauma to hua hai usko. You will see hemorrhages in corpus callosum, which are missed on CT. and this has a very poor prognosis. This patient normally will not recover because there is nothing you can do. It carries a very grave prognosis. These patients eventually reach a vegetative state. Okay, eventually they reach a vegetative state. I won't say brain dead. Okay, brain dead has some criteria. So don't go to brain dead. Why patients have to stay? नहीं, वो पिक्चरों में दिखाते हैं, ऐसा कुछ नहीं होता. That is all पिक्चरों का. बेहोश मत होना, बेहोश मत होना. That's all in the movies. Okay, because it aids respiration. अदरवाइज ऐसा कुछ नहीं है, बेहोश हो गया तो उठेगा नहीं, ऐसा नहीं है. Right? So the problem with DAI is bad injury, bad trauma, normal CT. Diagnosed on MRI. These patients will not recover. And someone was asking what happened to Michael Schumacher. This is what happened to him. When he was having a skiing, he was skiing. You know what is skiing, right? When he was skiing, he had an accident at a high velocity. His head hit against a rock. He got a DAI. And he eventually entered a vegetative state. He never recovered. He's still not recovered. Carries a poor prognosis. बाकी वाले ट्रॉमास में ना ठीक हो जाता. ठीक है, तरीका थोड़ा कैजुअल था. आई डोंट नो, माइकल शूमाकर का तरीका कैजुअल था. poor guy. Okay, so this is about head injury. Your diagnosis should be clear, and if it's an acute bleed, you should do decompression. Keep it simple. No problems in any question that comes on these kind of topics. Okay, now come to chest trauma. Again, chest trauma, you will get one question. Pakka, one question will come from chest trauma, and it's very easy. 2-3 concepts. ये आ गए. Chest trauma में कुछ भी आए आपको आंसर आ जाएगा. Basically, chest trauma, like head trauma, can also kill you, but by different ways. Head trauma may you will die because the intracranial pressure will increase. Chest trauma will work very differently, obviously. Some things can kill you immediately, within minutes. And some things can kill you within hours, 2 days. So what can kill you immediately, within minutes, is counted as immediate threat to life. So the most fastest way of dying is going to be airway obstruction. So there are 6 things both together in immediate and urgent. Immediate wale plus urgent, if you put together, it is called as deadly dozen. 12 cheezein hongi, 6 yahan, 6 yahan. The fastest that will kill you is airway obstruction. Apart from this, there is tension pneumothorax, which we are going to discuss. Tension pneumothorax. PTX लिखा है मैंने, it means pneumothorax. Okay, short में लिखा हूँ. फिर बाद में पूछना मत PTX क्या है. Then you have cardiac tamponade, which also we will discuss. Then you have massive hemothorax. So these are the 3 important ones. These 4. Airway obstruction we have already discussed. These 3 we will discuss. Then there are some others, like there is pneumothorax. Tension pneumothorax का भाई है वो. And the last, ये change हुआ है. पहले यहाँ कुछ और था. Now they have given tracheobronchial injury. First, there was something else over here. I will tell you what. But ATLS has changed it. These are the things which can kill you within minutes. Then you have some things in urgent. So in urgent, one of the things is flail chest. Earlier, this was an immediate, पर इसको उन्होंने निकाल दिया. They said ये immediately नहीं मारना. It takes time. So you have flail chest. Then you have lung contusion or lung injury. Then you have myocardial contusion. Then you have aortic rupture, diaphragmatic rupture, and esophageal rupture. Okay, these things can happen, but they will not kill you immediately. How can aortic rupture not kill you immediately? अजीब नहीं लगा आपको? Shouldn't aorta, if it tears, it should kill you faster than airway obstruction also, technically. हाँ, aortic rupture is not killing you. Shouldn't it be immediate? सोचा नहीं इसके बारे में? सर कुछ भी बताते हैं, कुछ सेंस ही नहीं है। ये मैं नहीं बता रहा हूँ, ये सब टेक्स्ट बुक्स में ATL इसमें दिया है। ठीक है, सोचना है इसके बारे में. ओके, हाउ इज दिस पॉसिबल? हाउ इज airway obstruction something so, or how is aortic rupture something so dangerous sounding, not immediate threat to life? How is it? How I put it in urgent? How can it kill? Take time for it. नहीं, सर्जन बोल रहा है तो बिल्कुल विश्वास मत करना, सोचना है इसके बारे में. नहीं नहीं अनुराग कुमार, थोड़ी चीजें सोचनी पड़ती है, right? So airway obstruction we have discussed. We will discuss these now. They are the important ones which come in the exam. So तीन चार बार पूछा है टेंशन न्यूमोथोरैक्स में, what it happens, we will put it in a simple way, एकदम conceptual way में समझेंगे. What is tension pneumothorax? Two words are there. The first is tension and the second is pneumothorax. Okay, pneumothorax means air in the pleural space. Okay, so you need to know what is pleural space first and why is it having tension. So if this is a trachea, trachea will become bronchi, bronchi will become lungs. Okay, and on the surface of the lung there is a membrane, right on the surface of the lung. What is this called? This membrane on the lung surface, patli si. It is also there in the GIT organs, also there on the heart, everywhere it is there. This is called as the visceral pleura. Okay, this is the visceral pleura. Outside the visceral pleura is your chest wall, means your ribs. So you'll have ribs like this. जिसके बीच में there will be some muscles. On the last layer of the chest wall, there is another membrane, एक और membrane, which is on the chest wall side, which also covers the lungs eventually, like this. This layer is called the parietal pleura. So if you see around the lungs, between the lung and the chest wall, you have a visceral pleura on the lung side, parietal pleura on the chest wall side. So these are the two pleural spaces. In a normal person, this space is very small and it has some fluid, little bit of pleural fluid. If air fills this space, you will call it pneumothorax. So pneumothorax means there should be air in this space. How will air come? Normally, ये हवा आती कहाँ से? बहुत रीजन है. It can happen because of a tumor. It can happen because of a rupture of a bulla. You know what is a bulla? ऐसा कुछ भी फूट जाए. अब हम कर रहे हैं ट्रॉमा. ट्रॉमा में क्या होगा? Let's say someone stabbed me in the chest like this. ऐसे मुझे stab हुआ. Okay, इसने चाकू मारा. Now when my chest wall is stabbed like this, there will be a tear in the chest wall and in the parietal pleura inside. So this parietal pleura will tear like this. Okay, ऐसे shape में tear हो जाएगी because of the stab. So now what will happen? This pleural space is connected to the outside world. So whenever I breathe in, I take a deep inspiration and this is already torn. So what will happen is when I inspire, the air from outside will enter the pleural space. So with every inspiration, pneumothorax builds. But when I'm going to breathe out, when I will expire, what will happen is this flap will go and close. So the flap will shut like that. When I breathe in, flap opens again. When I breathe out, flap shuts again. So every time I breathe in, flap opens, air enters. Every time I try to breathe out, air cannot escape. Air only remains inside. So like this, every breath, more and more and more and more air starts filling the pleural space. So the pneumothorax will keep becoming bigger and bigger and bigger. Okay, so far so good. So let's write this. Sometimes when there is a stab, there is a flap valve tear in pleura. Okay, this can happen even without a stammer. It can happen in blunt trauma also. So when he inspires, air enters the pleural space and he gets a pneumothorax. But when he breathes out, when he exhales, the flap shuts. And if the flap is shutting, unfortunately, no air can escape. Unfortunately. ठीक है, तो जब जब वो सांस लेगा pneumothorax बढ़ते जाएगा, and but he exhales, air cannot escape because the flap shuts. So what will happen is, over a few minutes, the entire pleural space is filled with air and the entire lung on the ipsilateral side has collapsed. लंग एकदम छोटा हो गया, pleural space पूरी बढ़ गई. But that's just the start. That's just the pneumothorax. If he keeps breathing, this pneumothorax will keep building and it will start pushing the lung to the other side. So what will happen is there will be a mediastinal shift. Now it is becoming tensed. जैसे आप लोग को टेंशन होती है ना एग्जाम के नजदीक, ऐसा समझ लो, रोज पढ़ रहे हो, एग्जाम के नजदीक कैसे टेंशन बढ़ते जा रहा है, वैसे प्लूरल स्पेस में टेंशन बढ़ रही. So there is going to be a mediastinal shift. And the pressure in the mediastinum is so much, यहाँ पर heart होता है, and your heart has your SVC over here and IVC over here. The pressure will compress the SVC. So there will be a SVC compression. And because of SVC compression, there will be reduced cardiac output. Means reduced venous return, and that will lead to reduced cardiac output. And because of this, the person will have a phenomena which is called as obstructive shock. So, बात की एक बात, in tension pneumothorax, the problem is not the pneumothorax. The problem is this obstructive shock, which is happening because of the tension. So this is what will kill the patient within minutes, and not the pneumothorax. Lung to collapse hogi. One lung will become non-functional, but other lung is there, at least for the time being. So it's okay. But the pressure inside the pleural space is so much, SVC is getting pressed. And if SVC gets pressed, no blood will fill in the heart. Cardiac output will reduce percentile. Are we clear about this? Absolutely clear. This is what happens in tension pneumothorax. The problem is the tension, not the pneumothorax. How you will get closer to the exam, how you will get tensed. Same. Right? Now moving on, how will this person present? ठीक है, चलो हो गया ये pneumothorax. पता कैसे चलेगा? Because this has to be diagnosed in airway breathing circulation. This cannot be diagnosed in secondary survey. Patient is dead by the time you reach secondary survey. This has to be diagnosed on the spot and managed on the spot. So how will the person present? He will present. So you are going to check his breathing and you have to identify he has pneumothorax. So जो भी साइड में pneumothorax है, राइट में या लेफ्ट में, on that side the air entry will be reduced or absent. It will be reduced or it may be absent. So you will be like, okay, definitely one lung has some problem. You will percuss. What note will you get on pneumothorax when you percuss? Normally, if you percuss on the lung, what note do you get? And in pneumothorax, what will you get? Normally, you get resonant note. Here, the resonance will become louder. So you get a hyper resonant. Hyper resonance, again, very dangerous. So it will be hyper resonant. You can also call it tympanic. Tympanic bhi bol sakte hai, but hyper resonance is better. So you have an idea, he has a pneumothorax. These two together means it's a pneumothorax. But I want to know, it's a tension pneumothorax. Tension है ये कैसे पता चलेगा? Tension पता चलना है. Pneumothorax भी तो हो सकती है, simple pneumothorax. So to come to know that he has tension, I have to look for certain findings of tension. Tension means obstructive shock. So what will happen is, his blood pressure will be low. He will be hypotensive. His JVP, jugular venous pulse, will be elevated. Because SVC, if it gets compressed, then the neck veins will become loaded. Blood is not going from the neck veins into the heart. Neck veins become prominent. Okay. These three together, hyperresonance, hypotension, and raised JVP, means he has tension pneumonitis. Baat khatam. He may also have tracheal deviation, may be there because of mediastinal shift. तो ये सब देखोगे ना तो पता चल जाएगा, हाँ बॉस इसको तो टेंशन pneumothorax है. You don't need to do anything, any x-ray, nothing. Diagnose it on the spot. Once you see it, within minutes you can diagnose. So he will come with a chest trauma. He'll be breathless. You will check his lungs. Airway will be okay. He'll be able to speak. But you'll check his lungs. One side, no entry at all. You percuss, hyperresonant. BP, low. Neck veins, distended. Trachea, deviated. Tension pneumonitis. Right? What will you do? Send him for chest X-ray. If by the time he reaches the chest X-ray, he's dead. So this is a clinical diagnosis. The first step that you are going to do is what is killing the patient. What is killing him is not the pneumothorax. What is killing him is the tension. So first step, what you are going to do is you are going to put a very big needle into the pleural space. Moti si needle in the pleural space. What will this needle do? This needle will allow the air to escape. When he breathes in, air enters. But when he breathes out, air escapes. Because the air will escape, the pressure in the pleural space will reduce. The compression of the SVC will reduce. The tension will reduce. Pneumothorax to rahegi because it's communicating, but pressure will reduce. It will take away the tension. So what you do in the first step is what is called as needle decompression. Where do you put the needle? When you do needle decompression, where do you put the needle? What if needle also rupture? Lung is collapsed. So it cannot rupture. It's not possible. Because the lung is collapsed, right? And if it punctures, nothing happens. So you are going to put the needle in the triangle of safety. And they will ask you boundaries of triangle of safety. So you should know the boundaries. In front of the triangle is the pec major muscle. Anteriorly. Behind is the latissimus dorsi. LD muscle. Posteriorly. And inferiorly is the fifth intercostal space. Or the nipple. Or line passing through the nipple. That is the inferior limb. And this triangle of safety is in the just anterior to mid-axillary line. That's where the point is of the triangle, just anterior to mid-axillary line. बहुत बार इस पे MCQ पूछा है, बहुत बार, especially in NEET entrances. So what are the boundaries? Anteriorly, this muscle that you see over here, you can feel it, this fold of axilla, pec major, the muscle behind, which you can feel, जिसको wing muscle बोलते हैं, that is going to be latissimus dorsi. Inferiorly, fifth intercostal space, just in front of the mid-axillary line. That is your triangle of safety. In a child, it is second intercostal space and mid-clavicular line, but don't worry about child. They will not ask you child. Kalamveer, you remember for adult. Okay, so you do this. You put the needle, the air will come out, neck vein distension will go, blood pressure will improve. Then you want to prove yes, there is a pneumothorax. So after this, you will do a chest X-ray. Or you can also do EFAST. EFAST bhi kar sakte hain. And the treatment, end treatment, is going to be what is called as intercostal drain. So finally, you are going to do intercostal drain. So you put a big tube in the chest, which is called ICD, intercostal drain, and you attach it to a bag which is called underwater seal. That is the name of the bag, which is called underwater seal. ICD is also placed in the triangle of safety. Okay, like this. So you place the ICD in the triangle of safety, and then after a few days, once the pneumothorax reduces, you do X-ray, and X-ray shows no more pneumothorax, you can remove the ICD. ठीक है, आगे बात समझ में? If triangle of safety is injured, no, then you go one space up or down, but you stick to the mid-axillary line. 14 gauge, as small as possible. Is ICD inserted to the needle? To the needle nahi hoga. You remove, needle will be there. You do X-ray. Then you put ICD with the needle inside. If needle decompression fails, see, I didn't want to bring this up. I know why you are asking this, but let's not do it. If needle decompression fails, you do what is called as finger thoracotomy. But ये नहीं पूछेंगे. See, the problem is if you know too much, then you will only get confused. You do what is called as needle thoracotomy, finger thoracotomy. और फिर आप पूछोगे, how do you do finger thoracotomy? And then it will become too much. ये permanent treatment ही है. ICD is the permanent treatment. The tear in the pleura will heal by itself. उसको stitch करने की जरूरत नहीं. The final treatment is going to be ICD. Okay. ठीक है. So far so good. Yeah. So this is about tension pneumothorax. Something every doctor should know. Answer this. This is a PYQ. Very nice question. What if finger thoracotomy fails? It's like saying surgeon is failing. Finger thoracotomy won't fail. So let's talk about what is called as cardiac tamponade. Then you will get the answer to the question also. Cardiac tamponade. We studied balloon tamponade in portal hypertension, where the balloon was giving a tamponade to the varices. Here, blood around the heart is tamponading or compressing the heart from outside. That is cardiac tamponade. Cardiac tamponade happens when there is a sudden collection of blood in the pericardial space. So there is a sudden collection of blood. Usually it is blood in pericardial space. So like there was a pleural space, there is a pericardial space, in the space around the heart. And this will only happen in the setting of penetrating trauma. Blunt trauma mein nahi hoga. This will only happen in penetrating. Very unusual to happen after blunt trauma. So what will happen here is, if your heart is like this and the blood collects around it after trauma like this, even if it is as little as 50 ml and the blood is collected around the pericardial or cardiac tamponade. So what will happen is, in diastole or relaxation, the heart will not be able to expand because the blood is pushing it from outside. So there will be a reduced filling in diastole. And because there is reduced filling in diastole, there will be reduced cardiac output. And what will this lead to? Same thing, obstructive shock. So here also, patient will die of obstructive shock. You see the same thing over here. That heart is over here, and surrounding the heart there is a clot. So big problem. So how will the person present? Because here also he is having obstructive shock. It will mimic tension pneumothorax many times. So how will the person present clinically? He will present with stab to the chest. So any patient with chest trauma, you check airway, you check breathing. When you check his breathing will be a little okay because lungs and all are okay. So when you check his breathing, air entry will be fine. So air entry normal. And lung percussion note will be resonant. It won't be hyper resonant. It may be dull where the tamponade is, but baki ka lung to theek rahega. Then you will check his vitals. And when you check his vitals, here also you get hypotension. because of obstructive shock. You will get raised GVP because the heart is compressed. If heart is compressed, SVC will not fill. SVC will not fill. Neck vein will be distended, and you will get muffled heart sounds. So the heart sounds will not be heard very well. So you get muffled heart sounds. All this together is what is called as Bextrade. So here also clinically you know, but the idea is this hypotension, raised JVP, is also seen in tension pneumothorax. So many times you can be confused as a doctor कि इसको tension pneumothorax या cardiac tamponade है because दोनों की treatment बहुत ही अलग है. If patient comes with this, what will you do first? First step, आप क्या करोगे? Heart sounds in tension pneumothorax will be normal. Heart को क्या होगा tension pneumothorax में? So here what you will do is you want to confirm that there is blood clot around the heart. You will do E-fast. सिर्फ fast किया तो भी चलेगा. To look for pericardial fluid. The first जो हमने first लगाया था ना probe, it was for this to look for pericardial fluid. If pericardial fluid is present, I know he has cardiac tamponade. फिर क्या करोगे? If he has pericardial fluid, PT से कुछ नहीं होगा. Heart काम नहीं कर रहा because of a clot. So echo की जरूरत नहीं है. You want to remove the fluid. You want to remove the blood. There are two answers to this. One answer is needle pericardiocentesis. This is the old answer. Okay, this is the old answer. This is not given in current books. The best answer is going to be thoracotomy. Means you open the patient up, open his chest and remove the clot. If both are given, go for thoracotomy. This is preferred. Because many times, since it is stab injury, since there is blood collected, aspirate करने से वो blood निकलता नहीं. You will just waste time in putting a needle and aspirating the blood. Something which this can also mimic is called as massive hemothorax. So there are these three conditions which are very similar. What to do in thoracotomy? Open the chest, see the heart, see the clot, open the pleura, open the pericardium, remove the clot, and suture. So the bleeding stops. Heart can relax again, like how you will relax. Same. Now come to massive hemothorax. What is massive? Massive hemothorax. Now what is massive? How massive should it be? Excess means kitna excess? Half of the lung. No, it's not half of the lung. Like you had pneumothorax. Hemo means blood. Thorax means in the pleura. So when there is going to be bleeding more than 1500 ml in the pleural space, that's what you will call as massive hemothorax. So the amount of bleeding, so यहाँ पर air थी ना, here it was air. Now I'm talking about bleeding in the pleural space. It should be more than 1500 ml. That will be called as massive. Now when I say massive, अभी ऐसे कैसे इतनी सारी bleeding होगी उसको? How much can that happen? How much should it be? इतनी bleeding, थोड़ा unusual है. So this can happen in the setting of trauma, but when there is going to be chest trauma, there should be injury to some major arteries like intercostal artery. This is most commonly injured. So there should be injury to intercostal artery or internal mammary artery. Normally these are the arteries which are injured. So intercostal artery, internal mammary artery, इनके bleeding से इतना massive होगा that the lung will also collapse and his blood also excessively. How will the person present clinically? He will come with a stab or a chest trauma. You will examine his breathing. What will you see on chest examination? In this case, yeah, artery punctured due to trauma, correct. So what you will see is when you check the lungs, here also there will be decreased air entry because the lung will be collapsed. But when I percuss, I will get a dull note because there is blood. So here I won't get hyperresonance. Here the note will be dull. And when I check his vitals, here also he will have hypotension because 1500 ml blood chalega, but JVP will be low. Whenever the blood volume will reduce, neck veins will collapse. This person is having what is called as hypovolemia. So he will die of hypovolemic shock, not obstructive shock. Here it is hypovolemia because blood volume is reduced because blood has gotten leaked into the pleural space. So he comes with hypovolemic shock. What will you do next? How do you treat this? What will you do next? Don't say needle decompression. So what you're going to do is you will stabilize because he's hypovolemic. So you will give him IV fluids, you will give him blood and blood products. And to confirm that he has a new hemothorax, you can do a chest X-ray. Or here also you can do EFAST. It will show that there is fluid around the lungs in the pleural space of a massive amount. Eventually the blood has to be removed. So the treatment is going to be here also intercostal drain with underwater sealing. Is this really the treatment for a bleeding artery? Intercostal drain with underwater seal? Will it stop the bleeding? ICD से इंटरनल मेमोरी आर्टरी इंटरकोस्टल आर्टरी जो फटी हुई है वो थोड़ी ना अपने आप ठीक हो जाएगी. नो, तो क्या करूं मैं फिर? ये कैसे ट्रीटमेंट होगा? गिव ट्रेनेक्सा, वो दे दिया. Why dull note? Blood will give a dull note. Thoracotomy, ligate, no. So what you will do is no. You will do observation. You will observe, is the bleeding ongoing or has the bleeding stopped? हो सकता है ब्लीडिंग रुक गई हो सकता है ब्लीडिंग जारी हो. सो यू विल ऑब्जर्व कि भाई आईसीडी में आता क्या है. इफ आईसीडी हैज more than 1500 ml of blood, or if it is having more than 250 ml of blood every hour, so more than 250 ml of blood per hour for 3 consecutive hours, इसका मतलब बॉस अभी भी ब्लीड हो रहा है, ब्लीडिंग रुकी नहीं. In this case, you will do thoracotomy and repair. Are we clear about this? This is the fundamental you need to keep in your mind. There is an artery which has torn. Either it stops by itself if patient is lucky, or you have to do surgery to stop it. Okay, so it's all based on, is it ongoing bleed or bleeding has stopped? If you see any of these two things, bleeding is ongoing, open and suture it. If it's not so much blood, maybe the artery didn't tear fully, maybe it tore partially. It's possible. That's why it stopped. Okay. No, this cannot cause cardiogenic shock. Cardiogenic shock requires a cardiac disease to cause shock. This is not cardiac, na. Acute MI will cause cardiogenic shock. कुछ भी किधर भी confusion में problem हो जाएगी. This will not cause cardiogenic. This will cause hypovolemic shock. Okay, because this is secondary to hemorrhage. Fine. So ये हो गए आपके 3. Now, in a nutshell, how are you going to differentiate the 3 for MCQs? This is the most important table, very conceptual table. That tension pneumothorax happens because of a one-way valve. Okay, there will be a one-way valve. Cardiac tamponade will happen even if there is more than 50 to 100 ml of blood acutely in the pleural space. Massive pneumothorax, more than 1500 ml of blood in the pleural space. So that's why they happen. What will you see on examination? In tension pneumothorax, there will be reduced air entry, but there will be hyperresonance. In cardiac tamponade, normal air entry, normal percussion. In massive pneumothorax, reduced air entry, but the note will be dull. You get a dull note. Then you check the vitals. Here you will have reduced blood pressure. SBP will be low. JVP will be high. Neck veins will be distended. Here also SBP will be low. JVP will be high. Here also SBP will be low because of hypovolemia, but JVP will be low because of hypovolemia. So clinically you will differentiate the three. Next step here will be needle thoracocentesis in triangle of safety. Here you will do EFAST, then surgery, or needle pericardiocentesis. Here you will do IV fluids, blood, and ICD. Okay, so ये की पॉइंट से अगर आप कंपैरिजन करके रखोगे तो याद रहेगा SBP इज सिस्टोलिक BP. और क्या होता है यार SBP, ठीक है. So that's how you will be able to differentiate all the three because they all appear very similar. So there should be no confusion in any of this. Right? Answer this. Patient presents with history of RTA. Patient has subcutaneous emphysema. Air entry is absent. He is having hypotension. What will be the next step? What will be the next step? So, absent air entry, hypotension, this subcutaneous emphysema. This means, most probably, this means there is a large airway injury or a bronchial injury. This means the person is having tension pneumonitis. Okay. In no other condition will you get subcutaneous emphysema unless the airway, trachea or something is injured causing a tension pneumonitis. The next step will be needle decompression. Okay. So 100% you will get one question on some of these topics which you should know very clearly and very well. Now come to abdomen trauma. Abdomen trauma is the easiest. Okay, it is the easiest compared to head, chest, abdomen. Trauma wise is very easy. It's very straightforward. एक थोड़े 2-3 ट्रिक्स है, ज्यादा कॉन्सेप्ट नहीं है इसमें, 2-3 ट्रिक चाहिए. Now abdomen can get injured again in two ways. Actually there are many ways. It can get injured by blunt trauma, penetrating trauma. Commonly these are the two ways it gets injured. There are other ways also. It can get injured by blast injury and so on and so forth. The organs that are injured, you can divide them as solid organ or hollow viscera. Okay, when will spleen get injured, or when will you expect a abdominal trauma spleen is injured? This will happen. Yes, any idea? When will you think spleen is injured in abdominal trauma? Blunt से क्या होता है? Blunt से liver भी होता. Where should the injury happen? Which will tell you, oh, I should think about splenic trauma. So Nikhil is giving answer from the notes. Splenic trauma will happen when there is injury to left lower ribs. Okay, injury to left lower ribs. That's when you will suspect splenic trauma. When you will examine a patient, what you will get, there are two signs. There is one sign which is called Kehr's sign. Kehr's sign means if the spleen is injured and I palpate near the spleen, there will be a spleen injury here and there will be a blood clot over here around the spleen. So when I will palpate here, he will get pain in his left shoulder. That is a referred pain. So he will get left shoulder pain on palpation of the spleen. And the second thing is I will get a dull note. So there will be blood clot over here. I will get a dull note in the left flank. That is called as balance sign, where there will be left flank dullness. And this dullness does not shift. Normally, dullness in the flanks will shift. Like if you have ascites, the dullness will shift. This doesn't shift because it's clotted blood. So it will remain there. Even when I turn the position and I percuss there only, it will remain dull. That is called balance sign. This basically gives me an idea that yes, probably there is blood clot around the spleen. Liver injury, quite obvious, it will be injured. Then there is injury to right lower ribs. That's where liver will be injured. Okay, and liver is commonly injured in penetrating trauma. Blunt trauma से ज़्यादा penetrating injury. So penetrating trauma में liver injured होता है. When will kidney be injured, or when will you suspect that the kidney is injured? When will you suspect that kidney is injured? So, no, not back. Kidney injury will be happen when there is injury to the flanks. So, if patient comes with flank bruising after trauma, or if the patient says after trauma he is having blood in urine or hematuria. Hematuria after trauma means renal injury. Nothing else in the abdomen will give you blood in urine. Urethral rupture will give you blood and meatus. Bladder rupture, he is not able to mixture it. Only in renal injury, he will have hematuria, because when the kidney tears, some blood enters the ureters and then it can enter the bladder and it can be passed as urine. So hematuria, you will think about renal too. Okay, don't think about bladder rupture. Bladder rupture में urine होता ही नहीं, क्योंकि bladder फूट गया तो mixturate कैसे करेगा, है ना? So think about this. And the fourth are hollow visceral injury. So hollow visceral means person had a stab or high pressure injury and something like small bowel got ruptured, or colon or stomach got perforated, small bowel injury, colonic rupture, they can also get injured. If this happens, what will the person present with? If there is a hollow visceral injury, rupture of small bowel or colon, very good, excellent. Person will present with peritonitis. So no, don't say constipation. If anything ruptures, he will present with peritonitis straight away. Right. So clinically and on abdominal examination, you have an idea what has torn, what has not. So some of this you can identify on primary survey, some things on secondary survey, but at the end of the day, you need to know how to manage. So let's say patient comes with a trauma to abdomen. You did primary survey, everything was fine. You did secondary survey, you got some findings. What will you do next? After primary survey and secondary survey, in patient of abdominal trauma? No. Fast to ho gaya primary survey. You are going to do CECT. And on CECT, I get an idea which organ is injured and how much. Extent of injury I come to know on CECT. So there are two things that can happen. Patient comes with abdominal trauma and he is unstable. If he's unstable, what will you do in primary survey? So he comes with abdominal trauma, pulse is low, pulse is high, BP is low. So what you are going to do, unstable patient, you will do fast or E-fast. Chalo, E-fast likh do. You like E-fast, do E-fast. If E-fast shows free fluid, E-fast positive, then what will you do? Then you will do laparotomy. Okay, so unstable patient with abdominal trauma, fast positive, surgery. Baat khatam. If he is stable, then you will do secondary survey. You will do full examination. Then you will do CECT. Based on what you get in CECT, you will decide कि भैया आगे क्या करना है. Now CECT will tell me severity of injury, which is given by some grades. Those grades go from grade 1 to grade 5. You don't need to know those grades. That's why I've not put it over here. So CT will tell you kidney is injured, how badly, spleen is injured, how badly, वगैरह. So it will give you a grading system. Based on the grade of injury, you can decide what to do next. If the CT grade is from 1 to 3, means mild or moderate injury, you will do observation. Okay, you will do observation. If the CT grade is 4 or 5, or sometimes even 3, sometimes in 3, if it's 3, you get a finding which is called as contrast leak. ऐसा कुछ अगर दिखा ना आपको एग्जाम में, grade 3 with contrast leak, in this case you will either do surgery, laparotomy, or you will do angioembolization. Okay, so let's be very clear about this. Unstable, fast surgery. Stable, CT and decide. Low grades of injury 1 to 3, observe. High grades of injury, angioembolize or do surgery. Any evidence of patient deteriorating, you will do surgery. Means patient when he came he was okay, but after 2-3 hours he became unconscious. His blood pressure fell suddenly. You will do surgery. So any deterioration, surgery. What about hollow viscous injury? इसमें क्या करेंगे? Hollow viscous injury में क्या करेंगे? Why? In RR drop of hemoglobin, that means he is bleeding. That's why. And any hollow viscous perforation, obviously you will do surgery because you have to repair the perforation. Surgery and repair the perforation. So like this, whatever is the grade of injury and whatever is the organ injured, you can decide the management. Okay? So unstable patient, fast surgery. Stable patient, CT and decide. Low grades of injury, observe. High grades of injury, operate. Deterioration, operate. Hollow viscous perforation, operate. This one slide will give you the answer to management of anything in abdominal trauma, blunt trauma. All this applies to blunt trauma. This does not apply to penetrating trauma. All of this will apply to organ injury in blunt trauma. If you read the books, your mind will go crazy trying to understand kya karna hai, next step, operate, not to operate, observe. You'll go crazy. Now it's very straightforward. इस स्लाइड में आपको सारे ब्लंट ट्रॉमा के आंसर मिल जाएंगे. Seat belt injury, organ is mesentery. Okay, in seat belt trauma it is mesentery of small bowel. Answer this. Patient comes blunt trauma to abdomen. He is unstable. BP is low. Fast is positive. What will you do next? So fast positive, unstable patient, abdominal trauma. Please don't repeat fast. Go for surgery. Okay. एक बार fast positive आ गया बात खत्म. चलो. Sanu was asking this ना. बताइए. In seat belt injury, duodenum. सारे के सारे आंसर दे रहे हो आप लोग. ABCD. Answer is hollow viscous. So I'll tell you seat belt में सबसे commonly क्या होगा. In seat belt injury, most commonly injured will be mesentery of small bowel. This is most common, mesentery, followed by small bowel. Okay, so answer will be hollow viscous. It's not going to be duodenum or pancreas. Duodenum and pancreas, they normally get injured in children, following a very particular mechanism of injury. Anybody can tell? Very typical mechanism of injury will injure the duodenum and pancreas. ऐसे ही नहीं होता, एक पर्टिकुलर तरीके से इंजरी होनी चाहिए. कौन सी है वो? Bicycle what? Yeah, it is bicycle handlebar injury. It is due to bicycle handle or handlebar. तो जब बच्चा साइकिल चला रहा है and suddenly he breaks, then what will happen is the handle of the cycle will hit his epigastrium, and when it blows the epigastrium, it will strike against the pancreas and the duodenum. So it's bicycle handlebar injury. Yeah. Most common organ injured in penetrating trauma. What is the answer? Most common organ injured in penetrating trauma. Okay, very good. And most common organ injured in blast. If there is a blast injury. what will get injured most commonly? Lungs, hollow viscous, intestine. Okay, I'll tell you the order. It will be tympanic membrane. Obviously, सबसे पहले तो आपके कान बंद होंगे, followed by blast lung. Toward most of the IMP topics under the sun that you are going to get in trauma from general, head, chest, abdomen, right? So now come to something little change of scene. So today we first half of what we were supposed to do is done. Now we go to second half, that is breast cancer. So we do breast cancer, breast abscess, and then we go to goiter. So change of scene from the heavy duty trauma to little easy. Page number बता दो हर्ष जोशी को, help कर दो उसको. So who gets breast cancer? What are the risk factors? The most common risk factor, not really logical, but most common risk factor is going to be increasing age. वो तो है ही. But then there are some specific risk factors like obstetric factors, menstrual factors, which you should know. So something obstetric and menstrual. Understand breast cancer is a hormone dependent cancer. It is dependent on estrogen, which is why it is more common in women. Women have more breast mass, and of course women have more estrogen. Cancer can happen in man also. Male breast cancer होते हैं, but we don't have before the age of 12 years. Or if she has menopause at a late age. Early menarche, late menopause after 55 years of age. Or if she does not have any children, she does not have any children, no parity, nulli parity. So आजकल बहुत common because not many women want to have children, not many couples want to have children. Or even more important, late age of first child. So the age at which she bears the first child, if it's at a late age. ये number पता होने चाहिए. 12 years, 55 years, 35 years. They can come as a one-liner MCQ, which nowadays is becoming very common, which is why breast cancer is becoming very common. पहले ये सब नहीं था. पहले कहाँ आप 35 साल की उम्र तक बच्चे नहीं करते थे. 35 साल की उम्र तक 3-4 बच्चे हो जाते थे. आजकल ऐसा नहीं है. One important thing again, which is seen in modern day society, breastfeeding. That breastfeeding is protective. अगर आप बच्चे नहीं करोगे और बच्चे करोगे और उसको breastfeed नहीं करोगे, 3-4 महीने में ही आप top feeds पे डालना शुरू कर दोगे. So again you lose that protection. So remember, breastfeeding is protective. Especially if done overall for more than 1 year. मतलब हर बच्चे में 1 year नहीं, total duration 1 year. Means if you have 2 children and both were breastfed for 6 months, 7 months each, so you have to cross that 1 year protection. So breastfeeding is protective. Hormone replacement therapy again is a risk factor. So postmenopausal women who take HRT, because hormone replacement therapy will contain estrogen, so that will increase the risk. So HRT will increase the risk. Now make a point over here. OC pills, oral contraceptive pills, will marginally increase the risk. Okay, they are not really a risk factor. Marginal increase. ज़्यादा increase नहीं होगा. So for all practical purposes, OC pills do not increase the risk. The risk is very marginal. It's like 1.05 times. बस उससे ज़्यादा नहीं. ये होगा obstetric factors. Then there are some, what do you say, dietary factors, habitual factors, environmental factors, which also increase the risk. Certain environmental factors like obesity. So we did GIT cancers, all linked to obesity. Breast cancer linked to obesity. Alcohol consumption. Prior chest radiation. तो अगर किसी कारण से पहले चेस्ट में रेडियोथेरेपी मिल चुकी है, she had lymphoma or something, that increases the risk. What about smoking? Is smoking a risk factor for breast cancer? Or is it protective of breast cancer? Or it is unrelated to breast cancer? So No, it's not protective. Smoking marginally increases the risk of breast cancer. It does increase according to Bailey. इतना अफेक्ट नहीं है, थोड़ा बहुत अफेक्ट कर दे, बाकी चीजें बहुत ज्यादा अफेक्ट करती है relatively. Okay, relatively they are far more contributory. So that doesn't mean start smoking. Okay, smoking is protective in which diseases? Siddhartha asked a question. Any surgical disease which is protected? Very good. One is ulcerative colitis. Any neurological disease protected by smoking? Yeah, Alzheimer's. Yeah. Alzheimer's is protective. Most common risk factor is increasing age. सबसे पहले लाइन यही थी मेरी, increasing age. Then there is a contribution of family history, of course. Breast cancer can run in families. It can, especially if there are some known mutations which run in families. Did we study any other familial cancer? Have we studied any other familial cancers? Dietary contribution is alcohol, high fat diet. Yeah. So just like you have FAP, HNPCC, same way you have familial breast cancer. They are the same. In principle, they are the same. So familial breast cancers are going to be autosomal dominant. They will be aggressive because they are due to known mutation. Mutation is there since birth. They will occur at an early age. Normal patient में breast cancer कब होती है? 50, 60, 70. If I have a known mutation, I will get breast cancer at 25, 30, 35. So if I get breast cancer at a young age, it's likely that I am carrying one of these mutations. And these mutations I got from my parents because it is autosomal dominant. So there are two mutations you should know. Just like you had FAP, HNPCC, here you have BRCA1, BRCA1. If this mutation is present, if BRCA1 is positive, means if I am born and I do gene testing and BRCA1 is seen in me, what is my lifetime risk of getting breast cancer? So what is the lifetime risk of breast cancer? It will be, remember we did FAP, it was 100%. HNPCC, it was 80%. Here also it's quite high, it is 50 to 85%. Person with BRCA1 also has a risk of ovarian cancer. Same mutation can cause ovarian cancer. This risk is going to be about 40%. Similarly, if I have BRCA2 mutation, if it is positive, then the lifetime risk of breast cancer is also very high, 50 to 60% for breast cancer. And risk of ovarian cancer is about 20 to 25%. Unfortunately, these numbers should be known. At least breast cancer का तो risk पता होना चाहिए. Forget ovarian, no problem. But you should know FAP 100%, HNPCC 80%, colorectal cancer. Breast cancer, BRCA1 50 to 85%, BRCA2 50 to 60%. These four numbers you have to know. And they will also occur at an early age, 30, 35. They will not happen at 60, 65 because the mutation is there since birth. BRCA2 mutation is also seen in men. So in male breast cancer, you should check for BRCA2. So if a man gets a breast cancer, which I told you is very unusual, क्यों होना चाहिए किसी आदमी को breast cancer? He should undergo gene testing because it's unlikely he got it because of any of these factors. ये सारे factor तो उसमें नहीं होंगे, nulliparity, PT. So probably he got it because of BRCA2. BRCA2 is more common than BRCA1 in men. Okay? So these are some of the things you should know about familial breast cancers. It will run in families. It will occur at a young age. You get a 30-year-old, 32-year-old female with a breast cancer. Think about these mutations. Mother, father, sister also got breast cancer. Think of these mutations because they run in families. Right? Now come to the easy part. Woman gets breast cancer. How will she present? Where will it occur? What will it do? what questions will come? So first thing you need to know, which part of the breast does it occur in? Most common site. What is the answer? Where does the breast cancer normally occur? Yeah, very good. It will commonly occur in upper outer quadrant because that has the maximum breast tissue. So typically the tumor will be in upper outer quadrant most commonly. The woman will present with a breast lump. The lump will be hard. It will be fixed. And it will be rapidly growing. These kind of things will tell you that yes, it is probably a cancer and not a benign tumor. Benign tumor will be seen in younger women. 15-20-year-old women with mobile breast lumps will be benign. There are some features of tumor spread within the breast, which is very interesting, which is what you should know, which is what they ask in the exam. If I see the breast from the side, it looks like this. Okay, let's say this is the skin of the breast, and let's say here is the nipple areola complex. Now the breast is basically fat. It's made up of these lobules of fat. Which is the gland which will have the secretions. Whatever secretions will be there, they will be released in these ducts which open at the nipple. Right? What are these ducts which will produce the milk at the nipple? Lactiferous ducts. Excellent. So, breast basically has breast parenchyma, the glands, and the ducts. This is what the breast is mainly. It's a gland. Behind the breast, there is a muscle over here, just behind it. Very important muscle, just behind the breast, which is my pectoralis major, P major. Behind pec major, in some part there will be pec minor, little bit छोटी सी muscle होती है, and behind that will be the ribs. And behind the ribs will be the intercostal muscles, behind and within. So here will be ribs and intercostal muscles. What will be behind this? Behind the ribs and intercostal muscles, just out of curiosity. इसके पीछे क्या होगा? Answer in 2 words. Give the perfect answer. Thank you, Akash Gupta. You said what I wanted to hear. Parietal pleura. You'll have parietal pleura, visceral pleura, lungs. Okay, इसके अंदर. Anyway, this breast, as you can see, there is some gap between the breast and the skin, between the breast and the pec major. So how is the breast supported? Why is it not falling here and there? What is keeping it in place? So to keep it in place, there are these tubes which run from the breast and go to the skin like this. What are they called? Which hold the breast and support it to the skin. These are the Cooper's ligaments. Okay, these are the Cooper's ligaments. Now you will be like, sir, why are you telling us all this nonsense? इतना detail anatomy मैंने कोई चीज में नहीं पढ़ा, यहाँ क्यों पढ़ा रहा हूँ? Because a breast cancer will spread to these things and produce some typical findings. So where will the cancer spread and what findings will it produce? Let's say the tumor starts over here in the breast parenchyma, and let's say it grows in front and it starts infiltrating these ducts. If the ducts will get infiltrated, lactiferous ducts, they'll start getting pulled. So if the tumor will infiltrate the lactiferous ducts, this will pull the nipple inside. It will lead to nipple retraction, which is what you see in the image. See, this nipple is inside. Normally, nipple should be outwards. It should be everted. This nipple has gone inside. Why has it gone inside? Maybe there is a tumor which is going into the ducts. So it is pulling the ducts inside. That is going to be nipple retraction. Q1 nipple retraction, infiltration of lactiferous ducts. ये वाले. Sometimes the tumor can infiltrate the ligaments. Maybe it will infiltrate 1 or 2 ligaments over here. एक दो ligament में घुस गया, So it will pull the ligament inside. So where the ligament will get pulled inside, the skin will get pulled inside. So if the skin gets pulled inside, what you are going to get is called a dimple. So dimple or dimpling will happen due to infiltration of one or two Cooper's ligaments. Okay, one or two Cooper's ligaments. Is there anything else you see on the image? और कुछ दिख रहा है? डम्पलिंग नहीं है, डम्पलिंग हम खाते हैं. डिम्पलिंग मेरे को नहीं आते, कुछ कुछ लोगों को आते हैं डिम्पल, एक दो मसल जो अंदर घुस जाते हैं. व्हाट इज पूदे ऑरेंज? क्यों होती है? क्यों होता है पूदे ऑरेंज? That is what has been asked a couple of times. Pude orange. The third thing that you can get is what is called as pude orange. And this will happen due to edema of the skin or dermal edema. And why will there be dermal edema? This will happen when the dermal lymphatics are infiltrated. So whenever the dermal lymphatics get infiltrated, the skin will start becoming edematous because of lymphatic block. And because of this dermal lymphatics and dermal edema, the hair follicles become prominent, as you see over here. If the hair follicles stand out because of the dermal edema, you get this appearance which is called as pude orange. Yeah? So this is what will happen if the breast cancer spreads into adjacent structures, आसपास की चीजें. Apart from this, cancer can spread to lymph nodes. So cancer from breast can spread like how your esophagus, stomach, they also spread to their lymph nodes. Breast cancer can also spread to lymph nodes. It will typically go to the axillary nodes, which are in three levels. They are in level 1, level 2, level 3. Level 1 are the first, they are the sentinel nodes, like the anterior group, lateral group. They are all level 1, posterior group. Level 2 nodes are going to be central group. Level 3 nodes are going to be apical group. So from the breast, tumor can go to the axillary nodes. Can it go to any other lymph node apart from axillary? Any other lymph nodes which drain the breast apart from axillary? Supraclavicular will go from axillary only. It will go from breast to axilla, axilla to infraclavicular to supraclavicular. It will go like that. Very good. It can also spread to internal mammary nodes. Okay, it can also spread to internal mammary nodes. So internal mammary nodes, it will be involved only if the tumor is in the medial part of the breast. Medial part. Lateral breast tumors will not go to internal. So normally breast cancer will spread to one of these two or both of these groups of nodes. How will it spread? Hematogenously. If you notice, all cancers we have studied like this, the spread. Where will it go hematogenously? Bone. Which bone? Which bone? So hematogenous mets very common to bone, most commonly to lumbar vertebra. That is the most common, followed by femur, followed by thoracic vertebra. It can also spread to liver, lungs, brain, meninges, all this. So see, where all is the breast cancer spreading? It is spreading within the breast. It is spreading to axillary nodes. It is spreading to internal mammary nodes. It is spreading to lung, liver, bone, brain. Practically everywhere it can spread. Which is why in breast cancer, what the saying is, it's a local cancer with systemic spread. It is always going to be. It will never be just a breast cancer. It will be breast cancer with some spread somewhere. Somewhere it will be spread when you diagnose it. Unless you diagnose it very early, it will be spread somewhere. Okay, so solve this question. Easy question. दो बार ये question आया FMG में. Why is this question asked now? Okay. So what you see here is to the orange, it is due to infiltration of dermal lymphatics. Okay, it is due to infiltration of dermal lymphatics. All right. If a patient comes with a breast lump, what will you do first? What is the first step for a patient with breast lump? Mammogram, X-ray, USG, clinical investigation क्या होता है? Physical exam तो कर लिया. Depends on age, CRP, self exam. Okay. Whenever they ask you investigation in patient with breast lump, the first step that you are going to say, second is going to be some kind of imaging, can be mammogram is one of them, and the third is going to be some kind of a biopsy. अगर मैंने ये तीनों चीजें कर ली, I will get a diagnosis in 99.9% of the cases. Okay, so this is what is called as the positive predictive value of triple assessment. The diagnosis will be reached in 99.9%, practically 100% patients. So any patient with breast lump, you will do triple assessment. Okay, you will do triple assessment. What investigation between these, which one will you choose, that we will see later, but get the idea clear. Any patient with a breast lump or even nipple discharge, the first step will be triple assessment. In all cases of lump or nipple, treatment of breast cancer, some benign breast disorders, and we'll start with goiter. Okay, जितना goiter कर सकेंगे उतना अच्छा है. कुछ जो रह गया वो कल पे कर लेंगे. The triangle here means diagnosis. Okay, imaging and tissue diagnosis. Anyway, so whenever patient comes with breast lump or with nipple discharge, you are going to perform triple assessment. And triple assessment means history examination, imaging, and tissue diagnosis. So let's say you already did the examination. Now you have to decide which imaging to do. There are three choices when it comes to investigations and imaging. So we are on imaging and you have three choices. The first one, the obvious one, is going to be mammogram. What is a mammogram? That is the first choice. A mammogram is nothing but an X-ray. It's an X-ray of the breast. It's not a chest X-ray, it's a breast X-ray. And it carries a very low radiation. So compared to a normal chest X-ray, it is a very low dose radiation. So it can be done repeatedly, only 0.1 centigrade. उतना ही radiation होता है इसमें. Now you take two X-rays, or rather two views, when you do the mammogram, and they are not your apilateral, they are like apilateral. One view is called craniocaudal. So that is one view, craniocaudal, and the other view is called mediolateral oblique. Mediolateral oblique, MLO. तो आप दो व्यू में ब्रेस्ट का एक्सरे लोगे. Now how will this help me? It will help me identify lesions like these, which may look like benign or malignant. So when I see the report will give me some idea, is the lesion benign or malignant looking? Like a malignant looking lesion will have what are called as microcalcifications. So if on mammogram they see a lesion which has microcalcifications or it has irregular borders, then the radiologist will feel, okay, yes, probably this is a malignant lesion. Benign lesion will be uniform, smooth border, something like that. So based on this, they will give you a score, which is called as BI-RADS score. So they will give you a score that, okay, I saw this lesion on the mammogram. It had borders like this. It had calcification like this. The BI-RADS score is going to be between 0 to 6. Now, you don't need to know each and every component of BI-RADS score, but basically what it means is higher the score, more it is likely to be malignant. So higher score, more likely to be malignant. But that's all it tells you. Which means normally if the BI-RAD is between 1, 2 and 3, so if the BI-RAD score is between 1, 2, 3, it is benign. If it is 4, it is suspicious, which in Gen Z language you'll say sus. It is sus. So 4 is sus. And if it is suspicious, it will warrant a tissue diagnosis. Means definitely you should do some tissue diagnosis. If it is 5, then it is very likely to be malignant. And if it is 6, then it is proven to be malignant. So 5 and 6 imply malignant, simply put. So the score does not tell me is it a severe disease. It is only telling me that the chances of it being cancer are high. Okay? So that is what I come to know on mammogram. But understand, mammogram can only be done in women with breast lump. So if a woman has a lump, you will do mammogram if she is more than 40 years of age. Okay, so she should be above 40. On the other hand, if she is below 40 years of age, then instead of mammogram, you do what is called as sono mammogram. Okay, you do what is called as sonomammogram. Sonomammogram is an ultrasound. It's not an X-ray. It is an ultrasound of breast. Okay, so younger women, ultrasound breast, above 40, mammogram. And in a normal population, you can do screening mammogram. Screening is done in normal population, means women who don't have any lump. For screening, you will do mammogram. Again, after the age of 40 years, annually. So ideally, every woman after the age of 40 years should undergo a mammogram. Okay, annually. Because it's not that every lump she will be able to feel on breast examination. So better to do a mammogram from 40 years onwards. This is an American guideline. If you read Bailey, which I don't think you guys do normally, but in Bailey they give British guidelines which are a little different. So don't worry about that. For American guidelines will say annual from the age of 40 years. So either if a woman has a breast lump, I do a mammogram. So normally is what I will do, mammogram, if she is beyond 40. And if she is below 40, I will do a sonogram. So in most women with breast lump, when I do triple assessment, first imaging will be mammo or sonogram. If certain special scenarios arise where I need something even more sensitive, something even more better, not just an X-ray or just an ultrasound, I want to look exactly into the breast. I want something very specific, very sensitive. Then I will do MRI. So MRI, practically speaking, is the best imaging for breast. It is the best. It will give you an image far better than a mammogram. Then you should say, sir, वो सब में यही करो ना, तो सब में MRI क्यों नहीं करते? जरूरत नहीं पड़ती है. हर पेशेंट में MRI नहीं करेंगे, even though MRI is the best. वरना सारे MRI सेंटर्स पैसे बनाने लगेंगे, एक्सरे सेंटर्स बंद हो जाएंगे, right? No, it's because it's overdoing it. अगर आपको खाना खाना है तो आप बाहर से एक आदमी के लिए खाना मंगाओगे ना, आप 10 लोगों के लिए थोड़ी मंगाओगे. You are overdoing it. But when you have a party, you will call for 10 people if you are little generous. So same way, MRI is the best, but you're not going to do it in everybody. You do it only when there are some indications. Like you want a very sensitive test. If you want to know, is there a recurrence? Like patient has had a mastectomy and she feels, doctor, I can feel some lump. I'm not very sure. I will do MRI, not mammogram. Or if she has implants and now she feels there is a lump. Like this is an MRI in a woman with implants. And if she feels there is a lump, I will do MRI. Or if she's a high risk patient. High risk means someone who is BRCA positive. So if she's BRCA 1 or BRCA 2 positive, then I will not do screening mammogram. I will do MRI. And in them, you will do annual MRI for screening. from the age of 30 years. Because I told you, BRCA patients' cancers will occur early. So MRI will be done in certain cases. In most cases, either you will do mammo or sonomammo. That becomes your part 2 of triple assessment. And part 3 is going to be doing some tissue diagnostic test. What is this? For tissue diagnosis, and what are the options for tissue diagnosis? ये क्या है? कभी देखा है? Can come as an image-based question. Yeah, it's not FNAC needle. This MOTA device, this is a true cut biopsy gun. Okay, it's much more than an FNAC needle. So for biopsy or for tissue diagnosis in patients with breast lump, I have two choices. The first one is FNAC. You can do FNAC. FNAC is done with a patla sa needle, normally 21 to 23 gauge needle. You do FNAC. You may have studied in pathology, but ideally you should do a core biopsy or a true cut biopsy. This is ideal. This is the investigation of choice. Okay, core biopsy, which is done with this device. Okay, core biopsy will tell you what type of tumor it is. Is it invasive ductal carcinoma? Is it invasive lobular carcinoma? Or is it a medullary carcinoma? तो जो भी उसके types है ना, वो मुझे biopsy पे मिल. So invasive ductal, invasive lobular, medullary, capillary, inflammatory. They are the different pathological types. तो वो सारे types मुझे biopsy पे मिल गए. FNAC पे इतना नहीं पता चलेगा. Right. So with this, I will complete my triple assessment. I did history, I did examination, I did a mammogram, then I did true cut biopsy. Now I know it is an invasive ductal carcinoma or it is a carcinoma in situ. What will I do next? What is the next step? After doing this, now you've studied enough cancers with me, so you better use your brains. Yeah, so I'm going to do staging. And for staging, I want to look at metastasis. For local staging, distant staging. For local staging, here also I will do CT thorax. And for distant metastasis, I will do PET scan. हो गई बात खत्म. PET scan में सब मिल जाएगा. Lung mets, liver mets, bone mets, सब मिल जाएगा. So I come to know the TNM stage. Breast cancer का TNM stage आपको पता होना चाहिए, because this has come twice in the last 2 years in entrances. Okay, so in GI cancers, what did T stand for? When we did GIT tumors, what was the T? Which was T1, T2, T3, T4. T stood for what? Mucosa, submucosa. Tumor what? What about the tumor? It spoke about tumor depth. Size nahi thi. It was tumor depth. Mucosa, submucosa, muscularis, serosa, and beyond. Here what you are talking about, इसमें depth तो है ही नहीं. इसमें कहाँ है mucosa, submucosa? Here T stands for size of the tumor or maximum diameter. Okay, it stands for maximum diameter. So if a woman has a breast lump, let's say the lump is over here, this is the lump, you will measure the maximum diameter. 2 centimeter, 5 centimeter, 8 centimeter, and so on and so forth. So that will give me the T stage. N will be nodal metastasis, M will be distant metastasis. So T here is tumor size. It is not depth. इसमें depth नहीं आएगा. So based on this size, you have this T staging. Easy. T1 size less than 2 centimeters. T2 2 to 5 centimeters. T3 more than 5 centimeters. You need to know this. Huh? This T staging you need to know. Then you have T4 A, B, C, D. T4A means tumor is invading chest wall. I told you this chest wall before. I'll just show it again. Chest wall is this part. This is chest wall, the ribs, the intercostal muscles. So if the tumor from here goes all the way back, goes to the pec major till the ribs, then I will say tumor is invading chest wall. If the tumor goes only till pec major, not till the chest wall, सिर्फ pec major तक गया ना, it doesn't matter. I will not say chest wall. Okay, so the tumor should go all the way till the chest wall. Then I know it is T4A. Please relax. Please stop interrupting. I don't understand what's wrong with you guys. You will just not stop interrupting. So, if it infiltrates the chest wall, not pec major alone, all the way till the ribs, or till the intercostal muscles, then I will say it is T4A. T4B is skin involvement, but not just any skin involvement. The tumor should show ulcer on the skin, or it should show पूरे orange, जो हमने पहले देखा. Like if I told you what is the T stage of this, it is showing पूरे orange. So this will be T4B. Dimpling wimpling is not T4B. It should show पूरे orange, or the tumor should cause an ulceration. Then I will say T4B. Pure orange. Or if you see multiple nodules around the tumor. So there is one tumor and there are chote other nodules. Satellite nodules. Then I will say T4B. Apart from this, if there are both chest wall involvement and skin involvement, then it is T4C. If the patient has inflammatory breast cancer, it is T4D. How do I know she has inflammatory cancer? पता कैसे चलेगा? It is T4D, inflammatory cancer. Abscess, no, don't say abscess. Abscess is abscess. So there are two things. Either it should be proven on biopsy, like you did true cut biopsy, it showed inflammatory cancer, or the Puy orange should be more than 1/3 of the breast. So if the extent of Puy orange is more than 1/3, then you will say it is T4D or inflammatory breast cancer. This was asked in FMG last year, not this year, last year. And you have correctly put inflammatory breast cancer as the poorest prognosis. It is the worst prognosis. Absolutely right. Which is why it has been put na सबसे नीचे. वरना आप उसको से अलग का कैटेगरी क्यों देते हैं? It is special category. Why? Because it's a very aggressive team. काफी बार ये ट्रीट नहीं होता. काफी बार. So T1, T2, T3 are based on size. T4, invasion of chest wall, means ribs or muscles, intercostal muscles, not pec major alone. T4B, skin invasion in the form of ulceration, पूरे orange, वगैरह वगैरह. T4C is A plus B. T4D is inflammatory cancer as seen on biopsy or large extent of orange. Right? This is the T stage. You will, many times they ask questions on this. In every FMG GT that I put one question. From T1, T3 can involve, it can, it may, it doesn't matter. Whether it is or it isn't. It doesn't matter. It can involve, yeah. Chota tumor can involve, but it won't affect the T stage. N stage is easy. If it is N1, then it will go to axillary nodes, but they should be mobile. Mobile means when I feel them, they should move. N2A means the axillary node should be fixed. So ipsilateral fixed axillary nodes. If they are fixed, that is N2. Yeah, less than 1/3. Obviously, na? In N2B, there should be internal mammary nodes. I told you internal mammary nodes are affected if the tumor is in the medial aspect of the breast. So medially located breast tumors will spread to internal mammary nodes. Where are the internal mammary nodes? How do I feel them? Feel कैसे होंगे internal mammary nodes? कहाँ पे होते हैं? Axillary nodes you can feel here in your axilla. What about internal mammary nodes? Where will you feel them? बहुत कठिन सवाल पूछ लिया मैंने. Yeah, so they are not felt. They are not palpable. They are seen only on imaging. like a CT chest. I cannot feel them because they are behind the sternum. They are retrosternum. Okay, so N2B is only on CT scan. It cannot be clinical. Then you have N3A, means ipsilateral infraclavicular, clavicle के नीचे. N3B is a combination of 2A and 2B. Means internal mammary nodes भी होने चाहिए, axillary nodes fixed होने चाहिए. And N3C is ipsilateral supraclavicular. Many times the student mix this up. They ask N3A and naturally you write supraclavicular, naturally. So don't make this mistake. And there is a simple reason. From your breast, it goes to axilla. From axilla, will it go supra or will it go infra? What is closer? Like we did head and neck cancer ke neck nodes. Na? We said now 1A, 1B, 2, 3, 4. Same way, if it's in the axilla, from axilla it will go to infra or it will go to supra. What is closer to the axilla? Obviously, it is infra. So, first it will go to infra, then it will go to supra. So, don't mix it up. N3A is infraclavicular. N3B, 3C is supraclavicular. Okay. All this is ipsilateral, same side, same side, same side. If a person has a cancer on the right, but they say left side supraclavicular, left side axillary node is enlarged, you will call it as metastatic. Okay. So any disease, anything on the contralateral side will be called as metastatic. Fine, cool. So that's how you'll come to know the T stage and the N stage. So based on this, they can ask you Guma Fira ke, but be ready for this that if Q de orange is more than 1/3, it is 4D. If it is less than 1/3, obviously it is 4B. Less than 1. Someone was asking this. More than 1/3, automatically it will become 4D. Right? Now come to treatment. Yeah, how will you treat breast cancer? Now you should be quite comfortable with a lot of cancers in your life. How do you treat a breast cancer? What is the first word that should come in your mind? First word that should come in your mind? Medical, local, surgery, surgery, depend. एक इंसान ने सही आंसर दिया. कोई भी कैंसर की ट्रीटमेंट will depend on the stage. जैसे GIT था वैसा ही है stage. Either it will be early breast cancer or it will be locally advanced breast cancer or it will be metastatic breast cancer. अरे यही तो किया है हमने GIT में, यही करना है यहाँ पर भी. Early breast cancer, what will you do? You will start with surgery. And then later, you will give chemotherapy. यही किया ना GIT में भी. यहाँ पर कीमो के अलावा you will also give radiotherapy. You will also give hormonal therapy. तो ब्रेस्ट में आप सब कुछ दोगे, कीमो, रेडियो, हार्मोनल भी. In LABC, what you will do? What will you do in LABC? Cancer, matlab staging, yeah. Same to same. It's the damn same thing. What will you do in LABC? Excellent. So first you will give neoadjuvant chemotherapy. Make the tumor small. So first give neoadjuvant chemo. एक बार वो छोटा हो गया, फिर करो सर्जरी, फिर देखो दे दो रेडियोथेरेपी, हार्मोनल थेरेपी. बस metastatic palliation. Please make your life easy. You have enough things to study in enough subjects in anat, physio, bio, micro, patho, medicine, OBGY. You will die studying so many things if you try to mug. Right? Somewhere apply some common sense and somewhere apply some systems in place, like we have studied in trauma, like we have studied in oncosurgery. So similarly, you are going to follow this system. You can remove the breast in metastatic also, but what is the aim of removing the breast? Will it help the patient? If I have a breast cancer and it has spread to the lung, liver, bone, brain, and you remove the breast cancer, you know the only person who will benefit from that will be you, because you will make money from the surgery. Patient will not benefit. You will remove it if the tumor is causing a problem, like it has become very large, it is fungating, and the patient just wants it for comfort. Means nikal do, But you will tell the patient, I will remove it, but it won't cure your cancer. Okay, breast will go, tumor will go from the breast area, but your life will not become any, means your life expectancy will not improve. Okay, so be clear about that. Yeah. In short, सच बोलो, वो तो कभी निकलने ही नहीं वाला. सच बोले, हाँ, कब सच बोलेंगे? नहीं 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 नहीं, बेस्ट सर्जन हूं मैं, आ जाओ आ जाओ आ जाओ, सब ठीक हो जाएगा. M1 डिजीज सब ठीक हो जाएगा, आई विल डू इट, यू कम टू मी. हम रेडिकल से रेडिकल सर्जरी करते हैं. So let's not do that. Yashika, chest wall is not involved without pec major. It is irrespective. Obviously, it is with pec major involvement. But if it is only pec major involvement, it is not chest wall. Okay. Sirf pec major is not chest wall. Chalo. So this is how you will decide. Now come to surgery. What surgeries do you do in breast cancer? There are only 2 surgeries you need to know. In the books, there are hundreds of surgeries. So first and foremost, when we talk about surgery, you need to know 2 surgeries. The first surgery जो पहले करते थे, आजकल थोड़ा कम हो गया, is MRM or modified radical mastectomy. Modified radical mastectomy. What is modified radical mastectomy? What do you do in this? Any radical means you will remove everything. So क्या modification करते हैं इसमें? You will remove the entire breast, means mastectomy. You will also remove the skin over the breast and the nipple areola complex. So let's say the tumor is over here. Let's say this is where the tumor is. So what you are going to do is you will take an incision which will remove the tumor and the skin of the breast, something like this, as an incision. So as an incision leke skin, nipple areola complex, entire breasts, the whole thing is going to be removed. And remember, any surgery where you see the word radical, you will also remove the lymph nodes. Okay, ये onco surgery का मतलब यही है, कहीं भी radical word दिखा ना मतलब lymph node निकालना है. So you will remove all axillary nodes. Means level 1, level 2, level 3. Which nodes are you not going to remove? Which nodes are you not going to remove? You will not remove any other node. Internal memory, infraclavicular, supraclavicular, वो सारे नहीं निकालने, सिर्फ axillary निकालने. ठीक है, तो इतनी रेडिकल सर्जन मत बन जाना कि छाती खोल के इंटरनल मेमोरी नोड निकालने चलो, ऐसा सब मत करना. राइट, सो दिस इज व्हाट यू आर गोइंग टू रिमूव. व्हाट आर यू गोइंग टू स्पेयर? ऑफ कोर्स, जो ओरिजिनल रेडिकल मैस्टेक्टमी थी ना हाल्स्टेड की ओरिजिनल, वो ये सब के साथ एक चीज और निकालता था, दैट वाज द पेक मेजर मसल. सो योर पेक मेजर स्पेयर्ड. This is the main difference between radical and modified radical. तो जो radical mastectomy थी ना पुरानी वाली, उसमें वो पेक मेजर भी निकालता था. Now think about radical neck dissection and modified radical neck dissection. उन दोनों में भी फर्क क्या था? One muscle was spared. Which muscle is that? Between MRNT and radical neck dissection, you spared one muscle. Which muscle was that? SCM. Excellent. Same way over here, you spare the pec major. Right? You also spare some nerves and other structures, which is given by the mnemonic ABCD. See, I have only used ABCD wale mnemonics. Huh? Child score ABCDE, acute pancreatitis ABCD. Here also ABCD. मैंने आपको कोई भी भलता mnemonic नहीं दिया, एक ही भलता दिया, choledochal cyst. But that is because you asked me for it. You said, sir, बता दो choledochal cyst कैसे याद रखेंगे? So I gave you 1 eye, 2 eye, 3 eyes. वरना मैंने कोई भी गंदा mnemonic नहीं दिया, अच्छे easy वाले दिए. So you will spare axillary vein, Bell's nerve. Bell's nerve is the nerve to serratus anterior. So you will spare Bell's nerve or nerve to serratus anterior. They come in the way. You will spare cephalic vein. So 2 veins will be spared, and you will spare dorsal nerve or nerve to latissimus dorsi. Okay, so these are the structures which you will spare in addition to pec major. Okay, pec major is not going to be removed. No other node is going to be removed. Only axillary nodes will be removed. But see, what is the basic thing that you are doing here? You are removing the entire breast. So if the woman is a young woman, 35, 40-year-old, and she does not want the breast to be removed, she will say, my tumor is only 2-3 centimeters. Why do you want to remove the whole damn breast for it? I still want to look young, feel young. I am desiring breast conservation. In this patient, you can opt for breast conservation therapy, also called as BCT. The key word here is therapy. So BCT stands for breast conservation therapy. Okay, and again I will say the key word here is therapy. Don't call it BCS. It's not BCS. It is BCT. It's not breast conservation surgery. What do I do in BCT? I do three things, and all the three things have to be done. The first thing is I don't remove the whole breast. I only remove the tumor with some margin, which is called as wide local excision. Like how in oral cancer you did wide local excision. Same way here you do wide local excision. तो पूरी breast नहीं निकालने की जरूरत. You do wide local excision with 1 centimeter margin, like you did for oral cancer. तो क्या पूरी breast नहीं निकाली, सिर्फ breast tumor के around की tissue निकाल दी. So 1 centimeter margin के साथ. So you are still leaving behind the breast. The second thing that you are going to do is you have to decide whether to remove lymph nodes or not. निकालना है कि नहीं निकालना है? Because see, in MRM, you removed all axillary nodes. It was a radical surgery. Axillary nodes निकालने ही है. यहाँ पर क्या करेंगे? निकाले या नहीं निकाले? What to do? To remove or not to remove? Remove. Yes. No. निकालना होगा. Remove all. Okay. So there are two things. One is if lymph nodes are already enlarged preoperatively, then you will remove all nodes. Then remove all axillary nodes. Okay, तो जबरदस्ती नहीं निकाल रहा हूं. अगर पहले से enlarged है तो ही निकाल. So I have to take a separate cut here on the axilla, open and remove level 1, level 2, level 3 nodes. However, if lymph nodes are not enlarged, पेशेंट को आपने एग्जामिन कर लिया, सीटी कर लिया, कोई भी एक्सिलरी नोड एनलार्ज नहीं, इफ नन ऑफ द नोड्स आर एनलार्ज्ड, तो क्या करेंगे? निकालेंगे या नहीं निकालेंगे? वो डाइट डालते हैं ना लिम्फ नोड में, जीवा तोड़े काय बोलते, biopsy. No. So what you are going to do in this case is something very unique. It is called as sentinel lymph node biopsy, SLNB, sentinel lymph node biopsy. This will help you decide whether to remove the axillary nodes or not. You do this technique. It is called sentinel lymph node biopsy. Now, what is the sentinel lymph node biopsy? Very easy thing. It helps me decide whether to remove the nodes or not, whether to remove axillary nodes or not. So what I do here is, I inject a dye around the tumor. So let's say there is a tumor over here. This is my axilla. So what I do is I inject a dye around the tumor during the surgery. What will happen is the dye will go into the tumor, and wherever the tumor cells are going, whichever lymphatics, that dye will go via the lymphatics to the axilla, and it will go to some of the axillary nodes. So what I do is I inject this dye, wait for some time, take a small cut on the axilla, and so I inject this dye. It is called isosulfan blue around the tumor, and after some time I take an axillary incision. I take incision on axilla. What will happen is one or two of the axillary nodes may have become blue. So I identify which nodes have become blue. What is so special about these nodes? एक दो नोड में वो डाई पहुंच गई होगी, क्या खास बात है उन ब्लू नोड्स में? No, it doesn't mean they are malignant. It means they are the first nodes draining the tumor or the sentinel nodes. They are the first nodes of the tumor. मतलब अगर ट्यूमर से कैंसर फैली हुई है, it will first go to these nodes. अगर नहीं फैली हुई है तो ये नोड तक तो नहीं पहुंची. So I identify these blue nodes and I remove them and I do what is called as a frozen section. Frozen section is like a histopathology. I send it to the pathologist who will give me a quick report within like 30 minutes. So 30 minutes के अंदर pathologist will tell me, is there any cancer cells in the node that I sent or not? So when I do the frozen section, pathologist, it is all in the OT. I am still waiting. I have not done anything. मैंने सिर्फ उसको नोड भेजी है. He should be close by. He'll check quickly and tell me. If the nodes show metastasis, that means the breast cancer has already spread to these nodes. That means metastasis is present. If there is metastasis, then I will remove all axillary nodes. All axillary lymph nodes will be removed. That's why I wait in the OT. Patient is under anesthesia. कि भैया एक नोड में कैंसर मिल गई ना तो सारे नोड्स निकाल. But if there is no metastasis, then you do nothing. Close the axilla. आई बात समझ में? तो अगर पहले नोड में कैंसर सेल्स नहीं है तो सारे नोड्स छोड़ दो. अगर पहले नोड में कैंसर सेल है, remove all the axillary nodes. Okay, that's why I'm trying to find out how the leader is. If the leader is corrupt, the entire population will be corrupt. If the leader is innocent and just, then can be sure that the population is also fine. That is the premise of doing this SLNB. कि फिर मुझे पूरी पॉपुलेशन निकालने की जरूरत नहीं है, सारे नोड्स नहीं निकालने. अगर पहला नोड ही ठीक है, बाकी के नोड्स भी ठीक. Okay, that is the premise. So SLNB will help me decide whether I should remove the axillary nodes or I can keep them behind. It will avoid कि बिना कारण नहीं निकालूंगा. क्योंकि MRM में I didn't check, I removed whether it has gone to the nodes or not. Radical removed. Here I will see if if the first node is metastatic, then remove it. But that's not the end of the story. After this, see, I kept telling you it is breast conservation therapy. Therapy means what? Therapy means after surgery, in all patients, I will give radiotherapy. So radiotherapy has to be given in all patients. So if I ask you what is BCT, it is wide local excision, lymph node whether to remove or not to be decided, and radiotherapy. तीनों चीज करेंगे तो आप बोलोगे breast conservation therapy. Okay, so now how do you decide if the woman has a cancer whether to do BCT or MRM? I have two surgeries. How to decide? Means whether I should do BCT, which is only a wide excision, or MRM, remove everything. Staging, patient desire, young. यंग तो क्या है यार, मैं भी यंग हूँ. 50 साल की औरत भी बोलेगी मैं यंग हूँ. Okay, no, it's not like that. It's not like that. So I'll tell you. In which patients do I do BCT? The indications for BCT. BCT can only be done in an early breast cancer, in a woman who wants breast conservation, in a woman desirous of breast conservation. Simple hai? So it should be early, it should not be LABC. And the woman should say, I want the breast to be kept. So then you will ask me, sir, then किसमें हम ना करेंगे? What is the contraindication? Where woman is having early breast cancer and she says, I want BCT, but you will tell no, only MR. ये कौन से पेशेंट है? Where it will be contraindicated. M1 मत बोलो यार, ऐसे आंसर मत दो. It's not M1. M1 में आप कुछ नहीं करेंगे. You will not give the option of BCT if there are two scenarios. If radiotherapy is contraindicated. Because if there is any contraindication to radiation, the treatment is incomplete. So I will say no, sorry, radiotherapy आप नहीं ले सकते. I can't do BCT. Best example is pregnancy. Pregnant patients, even if it is early breast cancer, sorry. Or if the woman has received chest radiotherapy before, prior chest radiation is already received, or any other contraindication to radiation, you can't do BCT. And the second scenario is if wide local excision is not possible. वाइड लोकल एक्सेशन तो कर ही सकते हैं ना, क्या बड़ी बात है उसमें? वाइड लोकल एक्सेशन क्यों नहीं करेंगे? So again, simple example, if the tumor is very large or it is a multi-centric tumor or tumor is very near nipple areola complex, ऐसी कोई ट्यूमर है, उसमें आप वाइड लोकल एक्सेशन नहीं कर सकते क्योंकि फिर कुछ ब्रेस्ट बचेगी नहीं. If most of the breast is removed, then what are you conserving? So contraindications are based on indications where wide local excision is not possible because the tumor is very big, there will be no breast left, or radiotherapy is not possible, you can't do BCT. Simple. So these are the contraindications. Contraindications are more important than indications. Indication तो एक ही है, early breast cancer, woman who is desirous of breast conservation, पर इसके बावजूद कम नहीं करेंगे, ये contraindication. Apart from this, you will give chemotherapy. I already told you. So chemotherapy, there are various regimens, but practically speaking, it will be given in all patients. All patients, if tumor is more than 1 centimeter. Okay, मतलब practically सारे patient में देना है. बात खत्म. For us, chemotherapy is given in practically all patients. Radiotherapy will be given in most patients. Okay, basically, if the patient is having a aggressive cancer, EGG is aggressive cancer, if there are lymph node metastasis, or you are doing BCT, BCT में तो radiotherapy आएगा ही, तो आप दे देंगे BCT में भी, आप दे देंगे aggressive cancer में भी, lymph node mets हुआ तो भी. So radiotherapy again in practically every patient. Hormonal therapy will be given only if the tumor biopsy shows ER/PR positive. Okay, ये एक ही चीज है which is dependent on the tumor. If ER/PR positive, you will give tamoxifen. If the woman is premenopausal, and if she is postmenopausal, you will give aromatase inhibitors. So these are the two groups of drugs you can give, aromatase inhibitors in postmenopause. For how long will you give them? This is given for how long? 1 month, 2 months, 5 months, 6 months, 1 year, 10 years. Very good. Not lifelong. It is to be given for 10 years. Okay. So this is the full treatment of breast cancer. I have given you each and every component, but if the fundamental is clear and the basic is clear, that early cancer, surgery, chemo, radio, hormonal, locally advanced, neoadjuvant chemo, surgery, radio, hormonal, metastatic will be palliation, and the two surgical options are MRM or BCT. BCT will be done in early breast cancer in a woman who is having desirous of breast conservation and who does not have any contraindication. Then you will do BCT. Otherwise, you will do MRM. Okay? Answer this. Woman came to the hospital with breast condition as shown in the image. What is the T staging? So you see Pude orange in a small area, this will be T4. If it was more than 1/3, it would be T4D. Answer this. What is considered as having good prognosis? Good prognosis. Which breast cancer is having good prognosis? From the options given below. Some options you can straight away eliminate. Right? खुद तो सीधा सीधा eliminate कर सकते हो. High mitotic index is obviously something very bad. It means tumor will spread. It will multiply. Axillary lymph node metastasis is obviously bad. That means there is already some spread which is happening. This is one of the most important prognostic factors. So if they ask you most important prognostic factor for breast cancer, it is axillary lymph node metastasis. HER2 new is a bad prognosis. All right. Simply put, ER/PR positive is good. HER2 positive is bad. Okay. There is one more thing which is called as mitotic index or Ki67. If this is increased, it is bad. Okay. These are some things that I get when I do biopsy of the tumor. Mucinous, colloid, or tubular breast cancers are good prognosis. And which is bad prognosis for breast cancer? Which type is the bad one? Which breast cancer is bad? Triple negative, lobular, no, inflammatory. The worst prognosis is inflammatory. Okay, so inflammatory breast cancer, worst prognosis. That's why it is given a separate stage. Right, so now answer this, and then you can also answer. Someone was screaming 2-3 times, sir, whoa, mobile lump ka answer, and I said, just relax. Where you were just not accepting that you need to relax, and you were just jumping on me. Batao. So, young female presents with a mobile rubbery mass in her breast. What do you see in the image? Anybody can decipher the image for me? What does the image show? ऐसी टिका दिया या रट लिया ये क्वेश्चन आएगा तो अच्छा वो नहीं आता. वही तो बात है, वो नहीं आता, इमेज नहीं आता. Indian file, okay. So what you see here is the compressed breast tissue. It looks like this. देखो, breast के अंदर ना gland होते हैं. Breast is a gland. Glands look like this. कोई भी आप organ का biopsy लोगे ना, which is a gland, it will have these. These are called as follicles or acini. And whatever is in between is the stroma. It's a supporting structure, supporting tissue. What you see here is stroma is too much. It is compressing the glands. Gland को पूरा दबा दिया है, stroma बना दिया. So I only see stroma. I don't see gland. This appearance is called as, in this case, it is called as staghorn appearance. You know staghorn? जैसे deer होता है ना, एक deer का प्रकार होता है जिसके horns होते हैं. These look like the horns of a deer. That is called as staghorn appearance. Barasinga, Barasinga, Lakshya picture wala. So the staghorn appearance, and of course, mobile lump in a young woman is going to be fibroadenoma. Invasive ductal and Phillips tumor will be fixed. Okay, they will be fixed. Right? LCIS normally does not present as a lump. And then you want to go back to that question you were screaming about. I will show you now here. Young female presents with a mobile breast lump which feels like a mouse. This will also be fibroadenoma. Fibroadenoma is typically seen between 15 to 30 years of age. It's a benign tumor. I told you it shows staghorn appearance. It is like a breast. It is a mouse in breast. And on mammogram or sonomammogram, अगर young है तो sonomammo करेंगे. It shows popcorn calcification. Okay, it will show popcorn calcification. How do you treat fibroadenoma? What is the treatment? What is the treatment for fibroadenoma? सेल्फ लिमिटिंग नहीं है, अपने आप नहीं जाता है, it will remain as it is. Yeah, so there are two things. If it is small and it is asymptomatic, you can do surveillance. If it is more than 5 centimeters, which is called a giant fibroadenoma, or patient wants to remove it for cosmesis, or it is having what is called as complex appearance, then you will do excision. Okay? So you will excise it if it's causing some problem. Otherwise, it's a benign tumor, nothing happens, it is not pre-malignant. Okay, it will not become from adenoma to carcinoma. ऐसा इसमें नहीं. ठीक है? And one last topic in breast, then we will go to goiter. That is breast abscess. Easy topic. बहुत 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 बार osmosis नहीं, cosmesis, not cosmosis, cosmesis. ये बहुत बार पूछा है breast abscess. So this is something you should know, and I'll tell you what answers have changed. Okay, there are some changes in the answers. Breast abscess typically starts off as a inflammation of the breast. So first what will happen is, if the woman is lactating and she has some cracked nipple is the most important predisposing condition. If she has a cracked nipple, most common risk factor. Then what will happen is, as the child will suck, the staphylococci will enter the lactiferous ducts. So Staph aureus commonly affects it. So there will be Staph aureus invasion, and it will cause inflammation of the breast. What is that called? It will start causing inflammation in the breast. What is that called? Very good. That is called mastitis. So the disease starts as mastitis. So if the woman comes with only some redness, some pain and redness, what she has is mastitis, and the treatment for mastitis is antibiotics like cloxacillin. Bailey may answer the cloxacillin. Right? So it starts like this. But if it is untreated, then what will happen? It will form an abscess. What is abscess? Abscess means what? It will start as mastitis, but then it will form abscess. Abscess, excellent. It will form pus. So there will be pus in the breast. Like how you had liver abscess, perineal abscess, here you have breast abscess. Right? It will present like this. So when there is pus, person will have high fever. Remember amoebic, pyogenic liver abscess, perineal abscess. So he'll have high fever. He'll have severe pain because pus is under pressure. You may feel a lump, very tender lump. So clinically, you have an idea that, okay, boss, it's no longer just mastitis. अब तो इसको abscess बन गया, and abscess बनना is a problem, right? So what will you do next? What is the first step when you are suspecting a breast abscess? First step, don't say IND. IND is not the answer. लिख the IND. So what you are going to do is going to be ultrasound of the breast, because she will be a young woman, less than 40. So if you think of triple assessment, history examination, imaging. Imaging pe you will do USG of breast. USG of breast will tell you two things. One is, yes, there is pus. But second thing it will tell you is the quantity. Chota abscess hai, bada abscess hai. Based on this, your treatment will be decided. If it's a small abscess, small means less than 3 centimeters or less than 30 cc. Small abscess, less than 3 centimeters, less than 30 cc. Zyada bada nahi. It has not ruptured or anything. In this, what you are going to do is you will do repeated aspirations. Okay, so for this, the treatment will be repeated aspirations. IND नहीं करना इसमें, रिपीट एस्पिरेशंस एंड एंटीबायोटिक्स। पहले के जमाने में IND करते थे, आज नहीं करेंगे। इफ द एब्सेस इज लार्ज, लार्ज माने more than 3 centimeters or more than 30 cc, or it has nearly ruptured, it's on the skin surface or very close to skin. In this case, old answer would have been IND. So answer would have been IND in past. आज के जमाने में IND नहीं करते. Nowadays, instead of IND, what you do is called as suction catheter drainage. Okay, so you see what options are there, and if both options are there, go for suction catheter drainage. Suction catheter drainage is done under anesthesia, but in that area, you don't make a big cut to drain the abscess. You make a small cut and put a suction drain. Yeah, like a Romovac drain. Absolutely right. So जैसे Romovac की तरह आप suction drain डाल दो, and it will keep slowly sucking the abscess out. You can keep it for 4-5 days, 1 week. No problem. The advantage is, since you've not done a big IND, you don't have to put any dressing. The woman can continue to breastfeed from the same breast. IND की problem क्या थी? फिर वो काफी दिनों तक ब्रेस्ट फीडिंग नहीं कर सकती till the wound heals. So this will allow her to continue to breastfeed. That is the main advantage. So you see what options are there. If this option is there, this will be the answer. Okay? क्योंकि मतलब एग्जामिनर ने ये क्वेश्चन बेली से सेट किया, उसको पता है इसलिए उसने ये डाला. वरना all the PYQ banks that you will see, they will answer it as IND, not anymore. Okay? How about breast? Answer this. Muffin milk होता नहीं है नॉर्मल. So cracked nipple, most important risk factor for mastitis. Okay, answer this. See how many questions have come. मैंने तो थोड़े ही डाले, वैसे बहुत क्वेश्चन आए. So female presents with redness, she is lactating. Cracked nipple is noted. Ultrasound shows significant collection. What should be the next line? Answer should be this. If this is not there in the option, go for this. Okay, if it is not there, right? Okay, now coming to the last part, that is going to be thyroid, and we will do some things in thyroid, some things which may get left today. I'll try to stretch till maybe 10, 15, 10, 30. Whatever gets left, we can continue tomorrow and then do urology. So in thyroid, some very basic things you need to know, जो एग्जाम में पूछते हैं, जो शायद आपने एनाटॉमी में पढ़ी हो ना हो, पर उसकी में ना गाड़ी नहीं बढ़ सकती. सिंपल चीजें. When I see thyroid, thyroid is also a gland. Like breast is a gland, thyroid is also a gland in the neck. Now, where does it lie? How do I reach it? If you go from outside to inside. So you have the skin in the neck over here. Underneath the skin, there is a muscle. What muscle is that? What muscle do you have underneath the skin in your neck? There is a muscle here. Once you have, excellent, that is platysma. So you have a muscle. So when you ऐसे करते ना, यहाँ पर lines आती है, that's because of platysma. Behind the platysma, you have some fat, superficial fascia. And behind this fat, you have some more muscles, which are called as the strap muscles, which come in the midline. They are called the strap muscles. Covering the strap muscle, there is a fascia. That is a deep fascia. ऐसे जाती है. And behind the strap muscles is your thyroid gland like this. Okay, and this little connecting part is what you call as the isthmus. This is how your thyroid glands in the neck. What is behind the thyroid? Somewhere here only in the neck. What lies behind? Very good. Behind this is trachea. So right here, just behind the isthmus, you will have the trachea, and behind the trachea you will have a esophagus, थोड़ा से compressed होता है, दबा हुआ, and behind the esophagus will be your vertebra. So this is your full anatomy आगे से पीछे. Now one thing that you need to know is ये जो deep fascia है ना, it will also cover the thyroid gland like this. It will form the capsule of the gland. So this deep fascia goes all around the gland. धीरे 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 forms the true capsule. This is the true capsule. But this true capsule, when it comes behind the thyroid over here, it will become thick and it will attach itself to the trachea. What is the structure which is attaching itself to the trachea? Very important structure in context of goiter. Yeah, this is the Berry's ligament. So what you see here is the Berry's ligament. And this Berry's ligament is responsible for, when you swallow, your goiter moves up, thyroid gland moves up, it's because of this ligament. This ligament attaches the thyroid to the trachea. So when I swallow, trachea moves up, Berry's ligament moves up, thyroid moves up. That's why thyroid moves up with swallowing. Apart from this, in the ligament somewhere here, you have two nerves which go from down to up between the thyroid and trachea. Very important nerves which run very close to the Berry's ligament over here. They are the recurrent laryngeal nerves. Okay, the most important nerves in the neck. So you have two recurrent laryngeal nerves. See how close they are behind the thyroid, in front of the trachea, in the Berry's ligament as they are going up. इसको छोड़ के thyroid के पीछे you have some artery. इतना पीछे नहीं, थोड़ा I'll draw it a little closer. You have an artery here. You have a vein next to it. And you have a nerve over there. What are these structures? What is this that I have drawn? Artery, vein, nerve. What is this all? Thyroid के पीछे. No, not Beers कुछ नहीं. Neurovascular bundle नहीं. This is the carotid sheath. Yeah. So this is the common carotid artery. This is the internal jugular vein. That is the vagus nerve. And all this together is my carotid sheath. Now you will be like, sir, why are you wasting time? It's 10 o'clock. Why do you want to speak of all this nonsense? Not nonsense. The idea is when the gland will enlarge in whatever disease, whenever the gland will become big, the structures that it will compress are these. So when the gland will enlarge, what will it compress? Recurrent laryngeal nerve. What will it compress? Trachea. What will it compress? Esophagus. What will it compress? Common carotid artery, internal jugular vein. They will get compressed by the gland. Okay. So when goiter causes problems, it is by compression of these structures. आगे तो सिर्फ muscle है, no big deal. पीछे के structures ही. So this is the basic anatomy that you need to know of the goiter. Second thing you need to know are the blood supply. So blood supply is, there are two arteries, superior thyroid artery, which supplies the upper poles. It comes like this, the superior thyroid arteries, which comes from external carotid artery. And then you have two arteries going over here like this, which are my inferior thyroid arteries, which come from subclavian artery. So you have a pair on each side, superior, inferior, superior, inferior. More important are the nerves. So there are recurrent laryngeal nerves, which run just behind the thyroid, and there is external laryngeal, which runs near the upper pole of the thyroid. There is external laryngeal nerve and recurrent laryngeal nerve. Where does the recurrent laryngeal nerve get injured when I'm doing thyroidectomy? कहाँ पर इंजर होती है और वो इंजर हुई तो क्या होगा? So if RLN gets injured on one side, unilateral, the person gets hoarseness. उसकी आवाज change हो जाएगी. It's very obvious. And the site where it gets injured is Berry's ligament. That is the site where it will normally get injured because that is where it is very close to the gland. So when I'm doing thyroidectomy and when I'm dissecting this area, freeing it from the trachea, that's when the nerve can get injured. So the site of injury of recurrent laryngeal nerve, this is what you should know, is going to be Berry's ligament. External laryngeal nerve is the most commonly injured nerve. What does it lead to if it is injured? Don't say this will lead to hoarseness. Huh? What does it lead to if it gets injured? ENT? This is actually ENT. No. Vocal cord dysfunction, hoarseness. No, it will not lead to hoarseness. Sure, kuch bhi. Hoarseness. Hoarseness is recurrent laryngeal. This will lead to loss of pitch. So the pitch of the voice will reduce. मतलब अगर आप मुझे गुस्सा दिलाओ और मेरी एक्सटर्नल लैरिंजियल नर्व इंजर्ड है तो मैं आप पे चिल्ला नहीं पाऊंगा. Normal speech will not be affected, but I won't be able to raise the voice. आपको गाली नहीं बक सकूंगा. So this is normally going to be noticed in singers. है ना? It is normally going to be noticed in singers. It won't be noticed otherwise, which is why it's very commonly injured, but it goes unnoticed. पता ही नहीं चलता. तो अगर आप थायराइडेक्टमी करो और आपने गलती से नस काट दी, पेशेंट कुछ नहीं बोलेगा, ठीक है कोई बात नहीं, no big deal, right? So these are the things which can get injured in context of goiter. Now coming to understanding what is goiter. Yeah, what is goiter? If any one of you have seen my Instagram, you have seen how much people struggle to answer these kind of questions. What is goiter? जिसको भी मैं पूछता हूँ ना, वो भी बेढंग के आंसर देते हैं. Adenoma. What kind of enlargement? Benign, diffuse. So if it is malignant diffuse, then it is not goiter. Is that what you're saying? It has to be benign. Iodine की कमी होने से, any type. Okay. So first and foremost, goiter means any enlargement of thyroid. Okay. Any kind of enlargement. Whether it is benign, malignant, whether it is diffuse, nodular, any enlargement. The problem with thyroid, you know what? I tell this in every class. We study thyroid the most. You study it in anatomy, physiology, biochemistry, patho, pharmac, micro, not in forensic, ENT, medicine, surgery, little bit in OBGY, little bit in peds, radiology. Some jagah you will study thyroid. And some jagah they will only confuse you. दिमाग की दही आपके EDH की इडली का डोसा बन जाएगा, लेकिन कंफ्यूजन कभी क्लियर नहीं होगा. क्यों? कोई बोलेगा हाइपोथायरॉयडिज्म, कोई बोलेगा हाइपरथायरॉयडिज्म, कोई बोलेगा गोइटर, कोई बोलेगा हाशिमोटो, कोई बोलेगा ग्रेव्स, कोई बोलेगा थायराइड कैंसर, कोई बोलेगा आयोडीन डेफिशिएंसी, कोई बोलेगा ड्रग इंड्यूस्ड. Like, what's happening? Then someone will say puberty, pregnancy, physiological. Total chaos. We'll be like, what is this big deal about this organ, this gland? Euthyroid. बहुत ही कठिन है. Let's simplify it. जो मैं बताऊंगा ना गोइटर के बारे में, उसके बाद आपको लाइफ में कभी कंफ्यूजन नहीं हो, कभी नहीं होगा. सिर्फ दो चीजों का you have to just understand two parts to thyroid gland. The first part is the goiter. You need to know how is the gland enlarged. Is the gland enlarged diffusely? Means whole gland has become big. That is diffuse enlargement. Is the gland enlarged with nodules? That is called as multinodular. Means पूरी gland size में नहीं बढ़ी है, some parts have enlarged. Or is it a solitary nodule. Solitary nodule means just one part of the gland has an enlargement like this. So first understand the anatomy of the gland. Second, ask yourself, what is the functional status? Functional means, is the gland enlarged diffusely, but the person is euthyroid? Is the gland enlarged, but the person is hypothyroid? Or is he hyperthyroid? Apply this to the three. Then just fill in the blanks. Every thyroid disease will fall in these categories. For example, diffuse enlargement in a patient with euthyroid means function is normal, but gland is enlarged. क्यों होगा ये? If there is too much demand, puberty, pregnancy, stress, where too much of thyroxine has to be produced. So what will the brain do? It will send TSH, gland will enlarge, it will produce thyroxine to meet your demands. This is called as physiological goiter. In physiological goiter, which is seen in puberty, pregnancy, any time when the demand increases, is going to be euthyroid. So gland बड़ा हो गया, and of course, once that period is gone, once pregnancy is over, the gland will shrink. Demand चलेगी, gland छोटी होगी. Diffuse goiter, which is hypothyroid. Hypo means बड़ा हो गया, लेकिन काम पूरा नहीं हुआ. ये कब होगा? This happens either when there is iodine deficiency, or it can happen in a disease called Hashimoto's thyroiditis. Hashimoto में क्या होता है? There are antibodies. They will start hitting the gland. Gland will enlarge to protect itself. It will keep hitting. Gland will enlarge, hit. But the gland is getting destroyed. So he becomes hypothyroid. It is antibody-induced damage. On the other hand, gland will enlarge and produce too much thyroxine, more than what is needed. ये कब होगा? This will happen when the gland is functioning too much by itself. Maybe the brain is sending too much TSH, causing the gland to become too enlarged. This is what is seen in Graves' disease. So in Graves' disease, you have those antibodies, TSH receptor stimulating antibodies. So they are produced in excess. They hit the gland starts getting enlarged, and it starts producing too much thyroxine. So person will be hyperthyroid, goiter will be diffuse. What I'm trying to tell you is, if patient comes with a goiter and you check his thyroid function, goiter is diffuse, but he's having hypothyroid, you should think of iodine deficiency Hashimoto. So when you describe someone as Hashimoto, you should say diffuse goiter with hypothyroid. When you label someone as Graves, you should say diffuse goiter with hyperthyroid. Okay? आई बात समझ में? ऐसा सोच के goiter पढ़ना. So then there will be never any confusion of goiter with what. Put these two things together, you will get all the etiologies. Come to the second one, multinodular goiter. ये nodules आए कहाँ से? What are these nodules? कहाँ से आ गए अचानक से? अजीब है. From where did you get these nodules? Any idea? Who produced them? Follicle, no. So multinodularity happens for a reason. Multinodular goiter happens when someone has a diffuse goiter. So it starts with a diffuse goiter, and there is a fluctuation in TSH. For example, you got pregnant, you got a physiological goiter. You delivered the baby, the goiter became normal. After a few years, you became pregnant again you got goiter. After you delivered, again goiter shrank. Then you had some illness, goiter. Illness went away, shrank. Increase, decrease. When this happens too many times, increase, decrease, some parts of the gland will start becoming nodular. So a multinodular goiter is nothing but a complication or a later stage of diffuse goiter. It can never start by itself. पेशेंट को शायद पता नहीं होगा लेकिन गोइटर हुआ होगा, अब जाके उसमें नोड्यूल्स बने। अब नोड्यूल्स में क्या होता है ना, नोड्यूल्स काम नहीं करते बट बीच का टिश्यू इज ऑलवेज वर्किंग। सो व्हाट विल बी द स्टेटस ऑफ द ग्लैंड if the beach cut tissue is working, only the nodules are not working? What will be the functional status? Euthyroid. Usually, this patient will only be euthyroid. So, MNG most of the times is euthyroid, and it has happened after previous physiological goiters. Now it will be euthyroid क्योंकि बीच का टिश्यू तो ठीक है, नोड्यूल्स काम नहीं कर रहे, हाइपोथायरॉइड नहीं होगा। If this goiter, multinodular goiter, remains for a long time, kabhi kabar na, some of the nodules go crazy. They start producing more than what is required. So the nodules become hyper. So sometimes MNG can also lead to hyperthyroidism. But MNG will never be hypo. Hypo ho hi nahi sakta. So hypothyroidism will always be diffuse. आई बात समझ में? लास्ट वन है सॉलिटरी नोड्यूल। सॉलिटरी नोड्यूल में कुछ भी हो, बाकी का ग्लैंड तो काम कर रहा है ठीक से, रेस्ट ऑफ द ग्लैंड इज फाइन, इसमें तो कुछ प्रॉब्लम नहीं है। सो व्हाट विल बी द थायराइड स्टेटस? इसमें क्या होगा? बीच का ग्लैंड तो सब काम कर रहा है, एक जगह पे नोड्यूल है। सो अगेन दीज गोइटर्स विल आल्सो बी यूजुअली यूथायराइड। Any example of solitary nodule which is euthyroid? This is seen in tumors. So tumors of the thyroid, thyroid cysts, they will be euthyroid. So papillary thyroid cancer, follicular thyroid cancer are all euthyroid. क्यों होने चाहिए? बाकी का ग्लैंड तो सही काम कर रहा है ना। Rarely, very rarely, the nodule goes crazy and it starts producing too much. कभी कभार होता है, ज्यादा काम कर। So rarely this can lead to a hyperthyroidism. This is called as toxic adenoma. So बात की एक बात, if you want to label someone with a thyroid disease, ask two questions. What is the anatomy of the goiter? What is the function of the goiter? Put the two together, you will get all possible diseases of the thyroid in this. Okay, no problem ever in your life. This is what you need to take away, because whenever you study any thyroid disease, just ask these two questions, you will get the diagnosis. And trust me, you speak to surgeons, physicians who deal with endocrine disorders, वो भी आपको ऐसे एक mind map देके नहीं बता सकेंगे, क्योंकि उतना clarity नहीं है, because we studied from so many places, it all goes crazy. दिमाग खराब हो जाता है, अब नहीं होगा। ये दो चीजें देखनी है बस। Everything falls in this. There are a few exceptions, congenital disorders, hypothyroidism, but वो बहुत rare है जिसमें गोइटर थायराइड बना ही नहीं। They are exceptions to the rule, but 99% of thyroid diseases will fall in this. बाकी का सब easy है, यही पार्ट समझना है। ये समझने में जिंदगी खत्म हो जाती है, लेकिन थायराइड नहीं समझता। बाकी का easy है। Patient has goiter. What will he come with? He will come with a swelling in the neck. So he will say, गले में सूजन है, and the swelling moves up on deglutition. So you know it's a goiter. So it moves up with swallowing. Any other problem person can come with apart from swelling? Any other problem person will have? So he can come with compressive problems. That's what I told you in the anatomy. He can come with problems of compression. So it can compress the recurrent laryngeal nerve, so patient can have hoarseness. It can compress trachea. He can have breathing problems, dyspnea, dysphagia if it is compressing the esophagus, and so on and so forth. Basically, whatever it compresses here, recurrent laryngeal nerve, if it compresses common carotid artery, he'll get fainting, syncope. trachea, esophagus. So goiter will compress. Okay, fine, no big deal. Second is if he has any of these functional problems. So he can also have, apart from swelling, hypothyroid features or hyperthyroid features. Hypothyroid means he will have intolerance to cold. This you study in medicine, I'm sure. Weight gain, lethargy, जो आप लोगों में काफी हो जाती है, अभी तक तो हो ही गई होगी. Hyperthyroidism patient will be intolerance to heat. Weight loss, anxiety, tremors, eye signs, all that. Now you know why. तो आप ये मत सोचना कि पेशेंट को ग्रेव्स डिजीज है. आप ये सोचना पेशेंट गोइटर के साथ आएगा, it will be a diffuse goiter and it could be with eye signs of hypothyroidism features, right? तो बहुत सारे आ सकते हैं. Compression symptom will either be absent or present. Yeah. So ऐसा पेशेंट आएगा ना तो आप ऐसा सोचना, बहुत इजी हो जाएगा, कुछ कंफ्यूजन नहीं होगा. बाकी का रेस्ट ऑफ द थिंग्स आर वेरी इजी. Sometimes a person has a typical complication which is called as retrosternal goiter. So goiter from the neck. So normally my goiter is entirely in the neck. But कभी कभार ना वो sternum के पीछे चला जाता है. You have the sternum over here and the goiter extends downwards retrosternally. But since it is going from the neck into the retrosternum, it will get the blood supply from the neck only. So blood supply is coming from the neck. क्योंकि सिर्फ extension है, तो जो inferior thyroid artery इसको यहाँ supply कर रही है, this will only be supplying the rest of the goiter. It shows a typical finding which you see here. What is this? What do you see here in this patient? Very classical sign that you see in this patient. This is called as Pemberton sign. It's a sign of retrosternal goiter. So what you are going to see is when he raises his hands, the face gets congested. So when he raises his hands above his head, the face gets congested. And this happens because the goiter, which is now in the neck, is compressing the SVC. तो यहाँ पर आपका हार्ट होगा, यहाँ पर उसकी SVC होगी. On the right side, मैं लेफ्ट में बनाया, तो यहाँ पर उसकी SVC होगी, and the goiter will compress the SVC. So when he raises the hands, the SVC will get compressed, neck veins will become prominent, and face will get congested. So it is a marker of retrosternal extension of the goiter. Puffiness होना जरूरी नहीं, there won't be puffiness. Just see his face here and see his face here, how red it has become. That is because of retrosternal extension. Many times students ask me, do I have to operate every retrosternal goiter? Means is the treatment always surgery? Means thyroidectomy is the only treatment for retrosternal goiter? What's your answer? Patient has goiter with retrosternal extension. What is the treatment? Surgery always, surveillance, medication, both. So please remember, it doesn't matter whether it is retrosternal or not. Surgery will be done only if causing problems. Okay, only if causing problems. If it is asymptomatic, you don't have to do anything. Right? So this will hold good for everything in goiter. So it's not necessary that you have to do surgery. And remember, the surgery will be done from the neck only. You do neck incision. तो neck से ही आप retrosternal goiter निकाल सकते हो. You don't have to do thoracotomy और sternotomy. वो सब करने की normally जरूरत नहीं है. ठीक है? Okay. Patient comes with goiter. What will you do first? What is the first test? This has come as a PYQ before. पहले पूछा है. First test. So here also you do what I call, okay, books में नहीं दिया, what I call as triple assessment. Okay, but थोड़ा अलग है ये breast से. Every goiter you have to do three things. First will be thyroid function test. Because I want to know the function of the gland. You hyper, जब तक वो पता नहीं चलेगा, diagnosis नहीं पता चलेगा. So first I do thyroid function, means I do TSH, T3, T4. Second thing is the same, I will do imaging. The imaging for all neck swellings is going to be USG neck. So USG neck is the first imaging in all neck swellings. What is it also called? USG neck for neck swellings. There is a dictum to describe this. So any patient with neck swelling, goiter, lymph node, you always do USG. Yeah, it is called as the workhorse imaging. It is called the workhorse imaging. माने जो भी patient को neck swelling हो, USG neck करना है. And the third thing is going to be tissue diagnosis. What tissue diagnostic test do you do in goiter? So you do only FNAC. FNAC is the only tissue. You don't do biopsy. Biopsy is contraindicated in goiter. Why? Why is it contraindicated? क्या बड़ी बात है, ब्रेस्ट में तो बायोप्सी करी, यहाँ पर आप नहीं कर रहे हो बायोप्सी. True cut nerve damage? No, it's not for nerve damage. Not for spread. Neither for spread. ब्रेस्ट में क्यों कर रहे हो? ब्रेस्ट में स्प्रेड नहीं होगा क्या? या तो वहां तो मैंने IOC बोला था. Can't detect. No. Biopsy is much better, but you don't do it. That's because the gland is very vascular, thyroid. So there can be a lot of bleeding. And thyroid के पीछे क्या है? If there is bleeding around the thyroid, what will happen? ठीक है ना, bleed तो bleed, क्या बड़ी बात है? Understand, behind the thyroid is the trachea. If it bleeds around the thyroid, the trachea will get compressed and the person will choke. He will choke to that. So I don't want things to bleed around here. It's a closed space. If it bleeds, trachea will get compressed. That's why you don't do biopsy. If you want to do biopsy, when do you do it and how? If you want to do biopsy, how will you do it and when? So that bleeding नहीं होनी चाहिए. एक ही indication where you do biopsy, and it's not a true cut biopsy. Cancer? No, not cancer. You do it only in one. There is only one indication for biopsy. Biopsy is done, and it will be an open biopsy. Open means कट करके gland देख के उससे टुकड़ा निकालो और फिर suture कर दो, so that you know there is no bleeding. There is no blind biopsy. This is done only in one case, that is to differentiate. There are two diseases. One is called anaplastic carcinoma, which is a very dangerous cancer. You want to differentiate it from Riedel's thyroiditis. All right. Only in this indication will you do open biopsy of the goiter. Otherwise, there is no biopsy. Okay, it's not excisional, it's incisional biopsy, not excisional. So ये दो चीज अलग करने के लिए आप कर सकते हैं. So most cases of goiter, you will do these three. Sometimes you will do this test. What is this? What is this imaging? कभी कभी करते हैं इसको, हमेशा नहीं करते. Sometimes it is done. This is called as radioactive iodine uptake scan. Radioactive iodine uptake scan. It basically looks at the thyroid function. And this is going to be done, हमेशा नहीं करते, 2-3 टाइम ही करेंगे. This will be done only if it's a sick goiter. So you see over here, Graves' disease, toxic MNG, toxic adenoma, इन सिनारियो में ही करेंगे. मतलब अगर आप यहाँ देखो, it will only be done in hyper. You goiters, हाइपोगोइटर्स में नहीं करेंगे. इट इज ओनली डन इन हाइपरथायरॉइड गोइटर्स, नॉट इन यूथायरॉइड, नॉट इन हाइपोथायरॉइड. उतना ही है उसका मेन इंडिकेशन. दूसरी scenario where you would do this is you would do this if the person is having thyroid cancer after you have removed the thyroid. So thyroid cancer, to look for metastasis after thyroid. इस सिनारियो में आप करेंगे thyroid scan. So if a person has papillary thyroid cancer, follicular thyroid cancer, you did the thyroidectomy, now you can do thyroid scan. Okay, means now you can do iodine scan. It's not called thyroid scan, you're looking for metastasis. ये दो जगह ही. So in most cases with goiter, after you have investigated, person will fall in one of these categories. Either you will have diffuse goiter, hyperthyroidism, hypothyroidism, multinodular goiter, euthyroidism. ऐसे करके कॉम्बिनेशन में आपको थायराइड की बीमारी मिल जाए. अब डिसाइड करना है करोगे क्या. व्हाट इज द ट्रीटमेंट एंड डू यू नीड सर्जरी ऑलवेज. व्हाट आर माय ट्रीटमेंट ऑप्शंस एंड व्हाट कैन आई डू. नो, it's not if symptomatic or malignant you will do surgery. No. First and foremost, you have three options to treat. So when I say treatment, first option is medical management. Medical management means if he is hypo, you will give him thyroxine supplement. If he is hyper, you will give him anti-thyroid drugs. तो ग्रेव्स डिजीज में जरूरी नहीं है सर्जरी देंगे. ग्रेव्स डिजीज में you can give anti-thyroid drugs. No problem. Patient will be okay most of the times. Do we do with iodine or technetium 99? You can do with either. There is no one over the other, whichever is available. Cold nodule, hot nodule के पीछे मत जाओ. Don't worry about it. क्योंकि उसका contribution बहुत कम है. Second treatment that you have for thyroid is what is called as radioactive iodine ablation. This is one of the treatments. This is what is used in Graves' disease. RAI ablation. And the third treatment is surgery. So when will I do surgery? It's very simple. Surgery is going to be done for only three indications. One is the patient has cancer. Second is the patient is having complications like compression. Third is the patient wants it removed for osmosis. बस ये तीन जगह पर ही आप थायराइड की सर्जरी करो. So any thyroid cancer, you will do surgery. Cancer is causing compression, you will do surgery. Patient says goiter is very big, please take it out, you will do surgery. And this I am telling you is not a lot. Most patients, most people with goiter, they have no problems. They live with it. तो सर्जरी का रोल गोइटर में इन सिनारियो में ये. बहुत बड़ा गोइटर है, कंप्रेस कर रहा है, निकाल दो. ग्रेव्स डिजीज है, मेडिकली मैनेज नहीं हो रहा है, निकाल दो. कॉजिंग कॉम्प्लिकेशंस, निकाल दो. थायराइड कैंसर, रिमूव. Okay. What you need to know about the surgeries, so there are different types of surgeries. I'll tell you the important ones. The most basic surgery is hemithyroidectomy. What do you do in hemithyroidectomy? What is this hemithyroidectomy? What do you remove in hemithyroidectomy? One lobe, partial, half thyroid. So in hemithyroidectomy, what you are going to remove is going to be one lobe with isthmus on the affected side. Basically, if the tumor is over here, what you are going to do is you will remove that lobe and the isthmus also. That is hemithyroidectomy. What is subtotal thyroidectomy? What do you do in subtotal? Bilateral isthmus. Both lobes and isthmus. तो सभी निकाल दिया ना. Leaving one lobe, वो तो हेमी हो गया. Almost all. टिप को छोड़ के पूरा 8 ग्राम ऑफ टिश्यू सब अपने अपने आंसर. Okay. Subtotal, you will remove most of the tissue, but what you are going to leave behind is some tissue on both sides. So ये सब आप निकाल दो. What will be spared is just some rim of tissue on each side. थोड़ा सा. But on both sides, all this will be spared. And this amounts to about 8 grams each. Okay, about 8 grams on each side. The third is going to be near total. What is near total? Nearly सब निकाल दोगे उसमें. What do you do in near total? Why? I'll answer why in a bit. इसमें what you do is one lobe you remove full, one isthmus you remove, other lobe you remove almost full. So what you are leaving behind is some tissue only on one side. सिर्फ इतना इतना छोड़ दो एक तरफ. Okay, this amounts to about 4 to 8 grams on one side. And the last one is total thyroidectomy. Total, you know what is total? Total में क्या करोगे पता है? Self explanatory. पूरा का पूरा निकाल दो. पता कैसे चलेगा पूरा निकाला है? सब निकाल दो पूरा except base का part. You remove all thyroid that you can see. So you remove all visible tissue. Now let me break some reality in your life. आज के ज़माने में we only do hemithyroidectomy or we do total thyroidectomy. These two surgeries are not done. Okay, not done anymore. No thyroid surgeon will ever say I did subtotal near total. Either you do hemi or you do total. बीच का कुछ थोड़ा बहुत छोड़ना कुछ नहीं. They used to be done in the past. They are not done anymore. Why are we तो है नहीं. Why we were leaving? That's because you wanted to protect the nerves. So what they felt was, if I leave behind some tissue in the vicinity of the gland, it will protect the nerve. You know, जो nerve के पास run हो रहा है, ये वाला part. What they wanted to do was leave this part. ये वाला part. ना छोड़ दो, तो recurrent laryngeal nerve बच जाएगी. But what they realized was, छोड़ने से फर्क नहीं पड़ा. Nerve, if it gets injured, it gets injured. So they realized no point in leaving behind any tissue. Remove everything, but try to protect the nerve when you are doing it. The risk of nerve injury remained the same, irrespective of surgery. So it was pointless doing subtotal near total. Nobody does subtotal near total anymore. Either you do hemi or you do. Last thing we'll do is the complications, because they ask questions on complications. What can go wrong in thyroid surgery? What are the main complications that you can expect? What are the main complications? Recurrence. So there are quite a few complications you should know. I'll tell you the important ones. The first is patient can get post-operative hematoma. So I removed the gland from here and he had a bleeding. I did the thyroidectomy. Now there is nothing inside. Now there is just strap muscles in front, trachea behind, and he had a post-operative bleed. So he gets a hematoma, and that will cause a tracheal compression, most dangerous complication. This happens because of reactionary hemorrhage. So typically, this will happen within few hours after surgery, normally within 1 to 2 hours. Means you did the surgery, patient was shifted to the room, and in the room, he started becoming breathless. Dangerous. Breathless within 1 to 2 hours means there is a hematoma. In this case, what you have to do is immediately shift him to OT. If he is breathless, airway is blocked, you will have to do endotracheal intubation. And you have to remove all the sutures. Remove all neck sutures. Basically, the pressure has to be released because the clot is compressing the trachea. So you remove all neck sutures, drain the clot. It's like cardiac tamponade. What you do in cardiac tamponade? Thoracotomy, open the pericardium, remove the clot, do hemostasis, something like that. वो भी cardiac tamponade था. This is trachea tamponade. You want to relieve the trachea tamponade, right? You have to drain the clot. This is one complication. Other complication we already discussed, nerve injuries. ये तो हमने already discuss कर लिए. And the third, which is a very unique complication. So nerve injuries, normally it will be recurrent laryngeal, which I'm scared about. If it is unilateral, person will get hoarseness. If it's bilateral, what will happen? What happens if it's bilateral RLN nerve injury? Stridor. Don't say die. He won't die. He will have stridor. So person after thyroidectomy, if he has stridor, it can be hematoma also. It can be recurrent laryngeal nerve injury also. How will you know which one it is? Trachea compress होगा तो भी stridor होगा. And recurrent laryngeal nerve injury होगी तो भी stridor होगा. दोनों में stridor होगा. वॉइस चेंज नहीं होगी भाई. अरे सांस ही नहीं ले पाएगा. ब्रेथलेसनेस दोनों में होगी. एक में vocal cords are blocked, no air can enter exit. एक में trachea is compressed, no air can enter exit. Breathing भी hoarseness नहीं होगी कुछ भी. No, Siddharth Chaudhary, the GCS man, has said the correct answer. This will happen post-operative hematoma after some time. This will happen immediately. क्योंकि अगर nerve injury है, so the moment anesthesia is taken out, the moment he wakes up, he will have stridor on the table. जैसे anesthetists ने endotracheal tube निकाली, उसके vocal cords घुस जाएंगे अंदर, and he will be breathless on table. आई बात समझ में? So he will have stridor on table. इसमें confuse नहीं होना, दोनों एकदम same sounding है. दोनों में he'll be breathless, he'll have stridor, he'll be choking, he'll be uncomfortable. Nerve injury will be immediate. Post-operative hematoma will be later. Okay, and the last complication is going to be post-operative hypoparathyroidism. तो कभी कभी क्या होता है ना, during thyroidectomy, all the 4 parathyroids can become ischemic. All 4 glands sometimes become ischemic because their blood supply is the same. देखो पता नहीं चलता. And in that case, what will happen? 2 to 3 days post-operatively, patient will get hypocalcemia because parathyroid will control calcium. No parathyroid, no calcium. He gets hypocalcemia. So typically 2 to 3 days later, he will have perioral tingling. He may have carpopedal spasm if it's very severe. What do you do in this case? Patient, अगर आपको लगता है 2-3 दिन में उसको tingling mingling हो रही है और carpopedal spasm type features आ रहे हैं, क्या करेंगे? So, first step will be check his serum calcium and PTH. That is the first step. Check serum calcium, check PTH levels. Obviously, they will be low, and then you will give calcium supplements. बस easy है. 2-3 बार इस पे क्वेश्चन पूछा है, इतना ही करना है, बात खत्म. ठीक है? So we have covered most of thyroid. We only left with thyroid cancers, which we will do tomorrow. So tomorrow we will first do thyroid cancers, and then we are going to do urology. All right. So lot of nice things we have learned. Many important high topics. So I will see you tomorrow with whatever is left. Tomorrow we will continue. जितना भी बचेगा वो कल खत्म. ठीक है? Okay. See you guys. Good night. Have a good day.